بسم الله الرحمن الرحيم والصلاة والسلام على سيد المرسلين أما بعد. Welcome everyone to second day of critical care essential course which started yesterday in cooperation between Qatar Critical Care Society and IUG Medical College in Palestine. Today lectures and workshops is about how ventilators work. It shows you how to think about ventilators when you use various modes and how to know if they are doing what you are expect. Mechanical ventilation is still more of an art than a science. So today's lecture will lead you to expertise with the theory and the tools of the art. You will then be able to make the best use of actual clinical experience. In real life, we don't let our teenagers drive cars after simply pointing the controls on the dashboard. They have to sit through weeks of theory before ever getting behind the wheel. You can kill somebody with a ventilator just as fast as you can with a car. Certainly, there is a great need for understanding the basic physiological effect of mechanical ventilation. So at least we do no harm and ventilate our sick patient in an appropriate way. It's my great pleasure to welcome Dr. Nader Kharma. He's a pulmonology critical care senior consultant. He's the lead of the ventilator weaning unit in Hamad General Hospital. Also, I would like to welcome Dr. Mohsen Shaheen. He's a medical ICU consultant, and Mr. Damo, he's a senior respiratory therapist in HMC, sorry. The first lecture will be for Dr. Nader. So you can start now, Dr. Nader.
Sure. Assalamu alaikum everyone. Masal khair al-jamia. And Dr. Muhammad Qandil, everyone speaks Arabic in the audience, right?
Yes.
Except for Damo.
Yeah, except for Damo.
Okay, so I'm just checking because ممكن نصير نحكي شوي بالعربي وبالإنجليزي. طيب مساء الخير للجميع. Thank you very much for having me again. التقينا قبل شهرين في كورس مشابه أو قبل شهر يمكن والله ما أتذكر الأيام. And I was really happy to be part of this initiative by Dr. Muhammad Qandil, and I'm happy to come back again and participate in this teaching activity. Dr. Qandil told me that there is need for more discussions about ventilation modes, and I would like all of you to excuse me if my lecture is not fitting everyone's needs, because I'm starting with basic modes. I understand that you are in a crisis time. You have lots of sick patients with COVID, and some non-ICU physicians and non-ICU staff are working in the ICU now. So, so I thought maybe we'll start with basic ventilation modes, and then based on your feedback, we can adjust further sessions in the future based on what you need. Initially, I wanted to do 2 lectures, but I managed to put both of them in one lecture. So I will try to finish within 1 hour or so, and then if Dr. Qandil wants to take questions, or wait for Dr. Mohsen and Mr. Damu to present their session. So, Bismillah ar-Rahman ar-Rahim, we'll start the first slide. Can everyone see the slides?
Yes, I think so, yeah.
Yes, okay. So first I will start that I don't have any conflict of interest or disclosure in relation to this presentation. Our learning objectives today, we will simplify the complex nomenclature of different ventilation modes. We will try to understand the basic settings, trigger, limit and cycle concepts of mechanical ventilation. We will compare and contrast waveforms of different ventilation modes. And then we will describe the optimal way or a recommended way of writing basic ventilator orders. So to try and simplify things, I think it's most helpful to think about mechanical ventilation in 2 terms. First, think what is the mode of ventilation, and second, think what is the type of mechanical breath. And once you get that clear in your mind, you know your mode of ventilation and you know the type of mechanical breath, you will find that you can put things together. So it's like a Lego. You know, you are building your own house. You can have a mode of ventilation, like for example, CMV or SIMV, and your type of breath could be volume control breath, volume breath, or it could be pressure breath, or it could be pressure support breath. So that's what we will talk about here. So we have to understand that there are lots of names, like different ventilators call different modes, call the same mode different names. So you have to know what kind of machine you have in your place. And Dr. Khandil told me that you have, I think, Draeger machines and Mandray machines. We have some Draegers, but we have mostly Hamiltons. So every place have their own stock depending on many factors. So this is a simple table here. It just shows you how complex it can be. So if we can call certain modes of ventilation as standard modes, we can perhaps use the terminology CMV as continuous mandatory ventilation, volume control, and compare what different manufacturer calls them. So on your Draeger ventilator, and correct me, Dr. Khandil, if I'm wrong, I'm assuming they have Draegers there in Gaza.
Yes, yes, there is Dragon ventilator, yes.
And no Hamiltons or Puritan Bennetts?
Hamilton, I'm not sure. I don't think so.
Okay. So for example, yeah.
They can give us feedback also about what they have through the chat privately.
Sure, sure. So the CMV volume control, Draeger called volume assist control, or volume assured assist control. The CMV PC to be called pressure assured assist control. For example, the adaptive pressure control, or what we call PRVC on Mackay, VC plus on Medtronic, on Draeger, it's called pressure assured assist control volume guarantee, or VG. And the same goes for different names. Sometimes the respiratory therapist will say the patient is on CPAP, but they don't mean CPAP as continuous positive airway pressure only. They mean CPAP like spontaneous breathing mode, pressure support, which is called spontaneous pressure support, or SPONT PS. So basically, know your modes and know what you're dealing with in your place. So going back to what I said in this slide, basically there are modes of ventilation and types of mechanical breaths. If we start talking about modes of ventilation or ventilation modes, there are three main ventilation modes for most of our purposes. The first one is the continuous mandatory ventilation, or CMV, or what some ventilators call them assist control. And there is synchronized intermittent mandatory ventilation, or SIMV. And there is spontaneous ventilation. It's important to know that CPAP, or continuous positive airway pressure, is not a mode of ventilation by itself. If you put someone on CPAP of 5, you are giving them a level of respiratory support, like 5 centimeters of water, 10 centimeters of water. But this is not helpful in ventilation. This is present during inspiration and expiration. It's just respiratory support. If we now start talking about specific different modes of ventilation specifically, we will start with the CMV, or the continuous mandatory ventilation, also referred to AC, or assist controlled ventilation. It provides the patient with a clinician select number of guaranteed breaths per minute. The mandatory breaths can be triggered in two ways. It can be triggered by the patient or by the ventilator. So you as a clinician say, for example, I want to put the patient on CMV, or assist control, and I want him to receive 12 breaths per minute. And you can say that these 12 breaths per minute are the set rate. So these are the guaranteed breaths. But if the patient wants to take more breaths, then he or she can do additional spontaneous breaths beyond the mandatory breaths. And these breaths will be fully supported and are identical to the mandatory breaths. So let's say my set breath rate is 12, but the patient is taking 3 extra breaths. So the total will be 15. But the 3 extra breaths are identical and are fully supported to the mandatory breaths that the patient is on when you are in CMV mode. Now the breath type could be volume breath or it could be pressure breath, but this is a breath type, not a ventilation mode. And we'll talk about that later. So the mandatory breaths on CMV, whether they are patient or ventilator triggered, are similar to spontaneous breaths. So let's explain this on this graph, and I hope that everyone sees the cursor of my computer. So here on the y-axis you have volume or pressure, and on the x-axis you have time. So here let's consider that every 5 seconds the patient is taking a breath. And these are ventilator-triggered mandatory breaths. So this patient here in A could be someone who is very sedated, paralyzed. They are not able to trigger any breath. And these straight lines are ventilator-triggered mandatory breaths. Every 5 seconds, the ventilator will give a breath. Now in B, you see the dashed lines. These are patient-triggered mandatory breaths. So let's say that after 2 seconds, the patient triggers a breath and the ventilator knows that this is within the mandatory breath that the patient should receive in these 5 seconds. So it will deliver a full breath of similar magnitude, whether volume or pressure, to the mandatory ventilator triggered breath. And then the patient triggers another one in the second interval. But here in the third interval, what happens? The ventilator waits and the patient is not triggering any breaths. And by the end of the third interval, now it's time for the ventilator triggered mandatory breath. So the patient takes this one. So the first 2 are patient triggered mandatory breaths. They are all falling in within the allowed set rate, but the patient is triggering them. The third one, the ventilator waited till the end of the 5-second cycle and nothing happened. So it's time for a breath. Now in the third scenario on C, you can see a mixture of events. You can see the dashed lines, which are the patient triggered mandatory breaths. The very small, like the tiny dots there, these are the spontaneous breaths. So here in the same interval, the patient triggers a breath first and he receives the full support. And then before it's time for the next mandatory breath, the patient wants to take another one. So this other one is not a mandatory breath, although it's similar to the previous one being patient triggered, but because it's happening within the same interval, it's called a spontaneous breath. And because this is CMV, the ventilator will offer the same volume or pressure support. And then you go into the second cycle and the same thing happens. One breath is triggered by the patient and is counting as a mandatory breath, and the other one is an extra spontaneous breath. And the patient does it a total of 3 times in the third interval, and so on, so forth. Now, if you look here on the D, you can see that the patient triggers the first one and the second one, but he gets full support on the first one and less support on the second one. And this actually paves the road to my next mode of ventilation, which is SIMV. That's the difference between CMV here and SIMV, where SIMV, the patient will take extra breaths or spontaneous breaths, but if they come beyond the mandatory breaths set by yourself on the ventilator, the patient will only get the volume or pressure that he can generate. He will not get the full support. So to summarize, CMV mode summary, or what you call assist control, the clinician sets mandatory respiratory rate. You say, for example, I want 10 breaths or 12 breaths per minute. The mandatory breaths are either patient-triggered or ventilator-triggered. The patient may trigger any additional spontaneous breaths. However, the mandatory and spontaneous breaths are identical in support, whether volume or pressure. In addition to setting the respiratory rate, you have to set the breath type, whether it's volume control, pressure control, or adaptive pressure control. You have to set the fraction of oxygen, inspired oxygen, FiO2, and the PEEP. So this summarizes the CMV mode and takes us to the next mode, which is SIMV. Now, SIMV and CMV share many similarities. Both of them, you will have to set the respiratory rate. The mandatory breaths are patient or ventilator triggered, but if the patient triggers any number of spontaneous breaths beyond the mandatory breaths, they will always be different from the mandatory breaths. So that's the key difference between SIMV and CMV. In SIMV, the mandatory breaths and spontaneous breaths are always different. And I'll show you this in the next graph. So in SIMV, you need to set the respiratory rate, similar as CMV. You need to set the breath type. It can be volume control, pressure control, or adaptive pressure control. It can also be a spontaneous breath type like pressure support, FiO2, and PEEP. So here, to focus on SIMV again, this is the main difference here in panel D. This signifies or shows an SIMV example where a spontaneous breath is not fully supported like a patient-triggered mandatory breath. The patient will get, for example, you set the breath rate as 12 breaths per minute. The patient will only get 12 breaths per minute. If he wants to take 13 or 14 or 15, any extra breaths, he will have to do what he can. So some breaths will be 100 mil, some breaths will be 200, some will be 50. Now you can add pressure support to these spontaneous breaths to further augment them. You can say, for example, I will add a pressure support of 5, a pressure support of 10. So whenever the patient takes a spontaneous breath, it will be augmented by pressure support. This is an example of SIMV in a volume targeted ventilation. So here you have specified that the patient will get a certain amount of volume, and you have specified that the patient will get a set number of breaths per minute. However, notice here the negative deflection prior to the pressure. This is a mandatory breath, but it was triggered by the patient because there is a negative deflection prior to the pressure. Prior to the breath, there's a negative deflection. Here, the patient also tries to start another breath, but because it's not time for the next mandatory breath, the ventilator did not deliver the same mandatory volume. It delivered a smaller one because that's what the patient can pull. That's the amount of volume that the patient is strong enough to get. So this is an example of variability between mandatory breaths and spontaneous breaths that you would see with SIMV. Now, what happens if I add pressure support to SIMV? The same thing here. The first breath here is triggered by the patient, but it's a mandatory breath. So the patient will take the full amount of volume. But the second breath is triggered by the patient, but I'm helping the patient with some pressure support. I said that I'm giving him 5 centimeters of water of pressure support, and that will give me volume and flow proportional to the amount of pressure support you're giving and to the patient's effort. So far we talked about 2 different ventilation modes, the CMV mode, or what you call assist control mode in some ventilators, and the second one is the SIMV. It's called SIMV in most ventilators. And the third one is the spontaneous mode. And spontaneous mode can be called as SPONT or SPM. Some ventilators call it CPAP, PS. So in the spontaneous mode, there are no mandatory breaths. So you cannot specify how many breaths the patient should receive. So in spontaneous mode, the patient should be able to trigger the ventilator. If the patient is paralyzed or heavily sedated, or for like due to severe neurological dysfunction, they cannot trigger, or they're too weak to trigger a breath, they cannot be on a spontaneous mode. All breaths are spontaneous and triggered by the patient. And that's what you see. The interval between different breaths is not regular. The patient can breathe whenever he or she wants. However, to set the spontaneous mode, you have to specify the breath type. Do you want the breath type to be pressure support? And this is the most common type of breath that you combine with spontaneous mode. Or do you want it to be an adaptive pressure support type, which is a special kind of pressure support? And then you add the FiO2 and the PEEP. So now we've talking about different ventilation modes, the CMV, the SIMV, and the spontaneous mode. And now we will talk about different breath types that you can combine with the ventilation modes that I just talked about. Excuse me. So the first breath type is volume set breaths. And as the name implies, you are selecting the breath type to be a tidal volume. The second one is pressure set breaths. And in this case, you set a constant airway pressure throughout inspiration. So the first one, you may say, I will set a tidal volume of 400 mils. Every time the patient takes a breath, spontaneous or mandatory, they will get 400 mils. The pressure set breath, you are dialing a pressure. So I give 20 centimeters of water. Every time the patient is breathing, he will get 20 centimeters of water. So think about it this way. If you set the volume, the pressure will be variable. And if you set the pressure, the volume will be variable. So you can never control both the pressure and the volume. You can control one and the other will be variable. And what governs the relationship between the volume and the pressure is basically the resistive forces and the elastic recoil forces. So if you give a set volume to the patient, and then as you are delivering that volume, their lung compliance changes because of pulmonary edema or pneumothorax or ARDS, then the pressure will change, will likely go up if the compliance is worse. However, if you give the same tidal volume and the compliance improves, then the patient will have lower pressure. If you give the same tidal volume in an asthmatic patient during exacerbation, they will have a very high peak pressure. As the asthma improves with the same volume, the pressure will start coming down. On the other side, on pressure set breaths, it's the opposite. You control the pressure, and the volume will be the result of the patient's compliance and resistance. So if you are giving a fixed pressure and the patient develops a pneumothorax, the pressure will not change. What will happen is the volume will come down. The volume generated will be less. If you give a certain pressure in a patient who is asthmatic and their airway is very tight, the volume will be very low. And as the airway opens, the volume will start increasing because it's pressure control. So always remember which one you are controlling and which one is changing, which one is independent variable and which one is a dependent or variable. So volume control breaths provide the patient with a clinician selected guaranteed tidal volume, and that's one of the advantages that people who like to use volume control will mention, that I know that I'm guaranteeing tidal volume on my patient. The maximum flow rate and profile is specified. So on some ventilators, you can specify how fast the flow will be. And you can specify the flow profile. Is it a square waveform or is it a decelerating waveform? Other ventilators will give you a constant flow and volume control, but you can set the inspiratory, time or TI and the tidal volume. So you either control the inspiratory time on some ventilators or you control the flow rate and profile on another ventilator. But you cannot control the inspiratory time and the flow rate and the profile with volume control. So here is a pressure time curve characteristic of a patient on volume control. So it may look like a busy slide, but I want you to focus on 2 points, point C and then point E. Point C is what we call peak airway pressure. And this is the pressure that will register at the end of inspiration. And this pressure is reflective of both pressure required to overcome resistive and elastic recoil forces. So remember, when the air is pushed in the trachea into the lungs, the air has to overcome the airway resistance first. And then after it overcomes the airway resistance, it has to overcome the elastic recoil of the lung tissue. So if you apply an inspiratory hold at the end of inspiration, then the airway pressure will equalize with alveolar spaces, and you will go to a lower pressure plateau called plateau pressure. The difference between the peak pressure and the plateau pressure is the amount of pressure wasted to overcome airway resistance only. And that's why we call it resistive pressure or resistance pressure. The amount of pressure that is needed to go from peak to plateau pressure is the compliance pressure. That's why when your peak airway pressure goes up on volume control, you cannot be certain if it's resistance problem or compliance problem. It can be one or both of them. The only way to know is to get your plateau pressure. And then if the peak to plateau pressure is big, like more than 5, for example, centimeters of water, then there is a resistive problem. However, if the difference between your peak and plateau pressure is minimal, then it's likely that you don't have much resistance, and that most of the increase in the peak pressure is a result of increase in plateau pressure or compliance problem. Compliance problems could be something like excess water in the lungs, whether it's pulmonary edema from heart failure, or excess water because of ARDS, or there's a new infection or pneumonia, or the chest wall is very stiff because the patient is obese, or the abdomen is distended because someone have ileus or surgical abdomen or compartment syndrome. Anything that affects the lung or the chest or the abdomen can affect, like ascites, for example, in the abdomen. All of these things can affect the lung compliance. Airway resistance is things that can happen from the tube sides. If you have a very small endotracheal tube or mucus plugging in endotracheal tube, or all the way down to the lungs with tight airways, for example, in asthma patients or COPDers or anaphylactic reactions, all that will affect airway resistance. Here, C is compliance, and compliance is your tidal volume over delta P. And since we said that compliance pressure is the difference between plateau and peak, then delta P in this case is plateau pressure minus peak. So if you know your tidal volume and you know your plateau and peak, you can get your lung compliance. Okay, and that would be helpful, especially when you are dealing with COVID patients. Some of them, not all of them, but some of them will have compliance issues and poor compliance. Some COVID patients with ARDS will have normal compliance while they have severe oxygenation problems. And that gets us into the topic of different phenotypes, and it's not the topic of our lecture, but I think we touched on that last time we spoke. I spoke to you about this. So here I'm just showing different curves, different basically pressure curves, pressure time curves in volume control patients. And just to show you how different compliance, volume, and resistance can change your peak and plateau pressure. So the solid line that you see here is the peak airway pressure, and the dotted line here is an imaginary line. This line does not exist in reality, like you will not see it on a ventilator, but it corresponds to the plateau pressure. So here, the top of the dotted line is plateau pressure. And the difference between the peak and plateau is a measure of resistive forces, as I said, and the difference between the plateau and the baseline is a measure of elastic recoil or compliance forces. So here at baseline, you can see we have two different pressures, peak and plateau. What happens if the patient the same patient here develops a low compliance? Like, for example, he is developing ARDS, he has pulmonary edema, he has right main stem intubation. Someone is sitting on his chest. He has a big ascites in the abdomen, okay? So then what you will notice, as I said, there will be a sudden rise in peak airway pressure. If the patient is on volume control, remember, we're talking about volume control, not pressure control. If they are on volume control, the nurse will call you and say, the peak airway pressure is high. What can I do? So you go at the bedside and you apply an inspiratory hold if the patient is well sedated and ideally paralyzed, and you get a plateau pressure. And you notice that with poor compliance, the difference between peak pressure and plateau pressure is not big because the airway resistance did not change. What changed was the compliance, and that's why the plateau went up, not the difference between peak and plateau. Now, what if you decide here, for example, you're giving 6 mils per kilogram tidal volume, and then you decide to give 10 mils per kilogram of tidal volumes. So the patient was getting 300, he's like, I don't know, 50 kilograms, he was getting 300, and now you want to give him 500 tidal volume. So what happens? Again, when you give more tidal volumes, you are stretching the lungs, and you are stretching it to the point where you are worsening the compliance of the lungs. So your peak airway pressure will go up. The difference between peak and plateau is the same, but the plateau pressure will go up because the compliance is worse. Now, on the other hand, what if it's a resistance problem? Also, the nurse is calling you at night because the peak pressure is high. But you notice that the difference between peak pressure and plateau is big. You check the plateau pressure, for example, like the peak pressure is 50. You check the plateau pressure, it's 25. So it's not very bad. The peak to plateau difference is 50 minus 25. So in this case, you know that there is a resistance problem. So maybe there's a mucus plug in the endotracheal tube. Maybe you need to suction the endotracheal tube. That will solve the problem, maybe. Maybe the patient has a wheezy chest. They have some exacerbation of airway disease. Maybe they need a bronchodilator or steroids. Maybe the patient has right main stem intubation. That would increase, mainly, actually, it would be a compliance problem, not resistance, but worth looking at. And maybe there's a problem with the circuit itself. You have to check the circuit, make sure there's nothing increasing the resistance there. What if you increase the flow? Also remember that airway resistance increases dependent on the flow. So if you were giving the patient, for example, 60 liters per minute of flow with volume control, and then you decide to increase the flow from 60 liters per minute to 100 liters per minute, that increase in the flow will increase the airway resistance because the air has to move at a faster rate in the same airway. And when it moves in a faster rate, the resistance will increase. So the peak airway pressure will go up, but the plateau will not go up. And the difference between peak and plateau will be high. Now, here, what happens if you add some PEEP to the patient? If you add a PEEP of 5, it's like a ladder that the patient is going up to. So the peak pressure will go up and the plateau pressure will go up by almost the same magnitude. So let's say the PEEP was 5 and you decide to increase the PEEP to 10. So you increase from 5 to 10. The peak pressure will probably go up from 25 to 30. And the plateau will go up maybe from 20 to 25. So that also keep in mind that a change in PEEP will change your peak airway pressure and your plateau pressure. In most of the times, there are situations where a change in PEEP may not result in an increase in plateau pressure if you are recruiting the patient. But most of the time, it will. What about flow profile? I talked about that volume control can be delivered with different flow patterns. What do you notice different between this pattern and this pattern? Well, I wish we could have had an interactive session. Usually this lecture, we give it, by the way, in our ventilation course. And we have like 20 people sitting in the room interacting with us. It's a little bit more difficult this way. But basically what you see, the flow here is a square waveform. and the flow here is a decelerating waveform. So imagine that in both cases, you are giving a tidal volume of 300. But the first way, you are giving it with a square waveform, and here you are giving the 300 tidal volume also with a decelerating waveform. Which one will take longer? Well, you can see that the inspiratory time here is longer than the inspiratory time here, because here you are developing the flow and at a steady rate. But in the other one, you are delivering the flow in a decelerating waveform. So it takes you longer time to deliver the same tidal volume. However, if you look at it, the peak airway pressure will be higher in square waveform of same volume compared to a decelerating waveform of the same volume. But because you are ultimately giving 300 mils of tidal volume in both cases, the elastic recoil or plateau pressure will be identical. So both plateau pressures will be the same, whether you use a square waveform or decelerating waveform. The difference will be the peak airway pressure will be higher in square waveform. Now, because you spend longer time in inspiration with decelerating waveform, it will increase your mean airway pressure. And this is not peak, not plateau. It's mean airway pressure, which is directly proportional to oxygenation. So if you increase your inspiratory time in a decelerating waveform, you have higher mean airway pressure, and the patient oxygenation is better. That's why in ARDS patients, decelerating waveform will give you generally better oxygenation because mean airway pressure is higher. Whereas in a COPDer, it's better to use a square waveform because inspiratory time is shorter. So you have longer time for expiration. And if you have longer time for expiration in COPD, this is a good thing because they have high airway resistance and they need time to expire or bring all the air out. If you use a decelerating waveform with long inspiratory time in COPD patients, you may end up with some air trapping. Of course, you can adjust air trapping by changing your respiratory rate, by changing your tidal volume, but that's something to keep in mind that flow profile can also have effect on inspiratory time and on different disease patterns from ARDS versus COPD. This is another way of showing the flow shapes in a cleaner way. This is a constant flow during inspiration, and this is a decelerating waveform. Now, you may see that the decelerating waveform in volume control makes volume control more similar to pressure control because, and I'll show you that in subsequent slides. So here is a cartoon showing assisted mode of volume targeted ventilation. So this is CMV in volume control. And you can see that the first breath is a controlled breath. The second one is assisted breath. And why is that? Because the first breath is not preceded by a negative deflection in pressure. So this is ventilator triggered, not patient triggered. The second breath is patient triggered, as you see the negative deflection. But both of them will result in the same tidal volume, whether it's ventilator triggered or patient triggered, because this is CMV mode. Remember what we said? We said in CMV, the mandatory breaths and the assisted breaths or the spontaneous breaths are supported to the same degree. So to summarize, volume control is volume set, it's pressure variable, it's time cycled. So I hope you understand that well. Volume set and pressure variable. So the peak pressure will change breath to breath and depending on the patient's clinical situation. It is time cycled and it is used with CMV or SIMV. You can combine volume control with CMV and you can combine it with SIMV. The clinician or the doctor will set the tidal volume accompanied by the inspiratory time or the flow rate and flow profile depending on your ventilator. Now we will talk about pressure control. So pressure control the ventilator maintains a constant airway pressure throughout inspiration. Remember, with the volume control, the airway pressure goes up gradually till the end of inspiration. In pressure control, it continues to be stable. I'll show you that on a graph. So stable pressure throughout inspiration with pressure control. You select the driving pressure and you apply it at the onset of inspiration. You specify TI, or inspiratory time. So you say, I want the inspiration to be 0.8 seconds or 1 second, for example. And you specify the respiratory rate on the mode. So here I'm putting volume control and pressure control next to each other, okay? So this is volume control, and this is, to the right, pressure control. Note that tidal volume is identical in both of them. Volume control here is delivering an X amount of volume, and pressure control is delivering an X amount of volume. It's the same. So it follows that the elastic recoil pressure or the plateau pressure will be the same between both volume control or pressure control. However, in the pressure control breath, the flow goes to 0 before the end of inspiration. So here, what do you notice here? When your flow goes down to 0, then what happens to your pressure? Remember, in volume control, when you apply an inspiratory hold, I'll try to go back to that slide to show you. When you apply an inspiratory hold, you have 0 flow conditions. And when you have 0 flow conditions, this pressure is called plateau pressure. In volume control, this image I'm showing you, when flow goes down to 0, there is no resistance. There is no airway resistance because the flow is 0. So the peak pressure in this case equals plateau pressure. So in pressure control, if you achieve 0 flow at end of inspiration, your peak pressure is the same as your plateau pressure. They are the same. And that's a convenience in pressure control compared to volume control. Here, however, you see that the peak airway pressure in volume control is higher than the peak airway pressure for the same delivered volume in pressure control. And the reason for that is that the flow, while not as high as pressure control at the beginning, but is persistently high throughout inspiration. The flow with pressure control is only high at the beginning and then goes down. And because of that, you have more airway resistance to volume control than pressure control. And hence, the peak pressure will be higher and the resistive component is higher in volume control. Does it make a difference to the patient? It does not make a difference for you because you care about plateau pressure, not peak pressure. Plateau pressure is what harms the lung, what harms the alveoli. Peak airway pressure is only a reflection of how much airway resistance you have. So that is not injurious to the lungs. Here, as I showed you on previous slides with volume control, how we change mechanics. If I change the compliance, the resistance, what happens? Here, I'm doing the opposite. With pressure control, if we change the resistance and compliance, what happens? So the first one is the baseline. Patient is getting pressure control, and he's getting the typical flow pattern in pressure control where it shoots up initially quickly and then it comes down, and he's creating a volume. Now, if I increase the driving pressure, say it was 15 here, and now it's 20, what do you expect will happen? The peak pressure will, of course, increase because you increase the driving pressure. But also, the volume generated will increase. Now, what if the patient, for example, is developing sudden decrease in volume for the same amount of pressure? So the nurse calls you this time and says, the patient is on pressure control, but I noticed that his volumes are less. He's getting less volumes. Then you as a clinician should think that this decrease in volume with the same pressure means that there is worsening of compliance or increase in resistance. And the only way to tell the difference is by looking at the flow time curve. If you see that the flow does not go to zero by the end of inspiration, it means that the drop in volume is secondary to increased resistance. And the reason is there's so much resistance that the TI is consumed, like the inspiration time is consumed, and the pressure still hasn't equalized, hasn't overcome the airway resistance. And that's why the flow did not go down to zero. In the second example here, the flow has gone down to zero because it's not a resistance problem. The pressure has overcome resistance in the early part of inspiration, and now it's a compliance issue. So if you see that the patient is getting less volume for the same pressure control, and the flow is going down to zero, this is usually a compliance issue. Think about a pneumothorax, pulmonary edema, worsening ARDS. Maybe you should do a chest X-ray, verify the position of the endotracheal tube, make sure that there's no new aspiration or infection or whatever. However, if you see that the flow is not going down to zero, you suspect a higher airway resistance. Look at the endotracheal tube and any mucus plugging, wheezing in the lungs, bronchodilators, suction, pulmonary toilet, and this kind of stuff. So to summarize, pressure control, it's pressure set, it's volume variable, it's flow variable, and time cycled. It's time cycled because you specify how much inspiratory time you want. And it's used with CMV and SIMV. You can combine it with CMV. So you can have assist control in pressure, assist control in volume. You can have SIMV in pressure. You have SIMV in volume. And in pressure control, the clinician sets the pressure and TI. So now let's talk about the third kind of breath type. So first we said volume control type, pressure control breath type, and now there's adaptive pressure control breath type. So adaptive pressure control is a hybrid of DC and PC. And on Drager ventilators that you use, it's called guaranteed volume, or GV. Sorry, VG, volume guaranteed, I guess. And in other ventilator, it's called PRVC. In other ventilators, it's called VC plus. Yes, in Drager, it's called volume guarantee, or VG. In others, it's called PRVC, VC plus, and other names. So basically, adaptive pressure control works this way. You set it on the ventilator as if you are setting volume control. You say, I want tidal volume of 400. But what happens is that this in reality is a pressure control, not volume control. The ventilator will change the pressure breath to breath to achieve the same tidal volume that you want. So you say to the ventilator, I want tidal volume of 400. The ventilator will start with, for example, pressure control of 15 or 20, and it will titrate the pressure up or down to achieve the tidal volume that you want, 400, for example. So in essence, it is pressure control, but it is a titratable pressure control to achieve the volume that you want. So it is combining the best of the two worlds. It's combining volume control with pressure control. But for you, as someone setting it on the ventilator, it's just volume control because you are putting in the volume. The clinician sets the tidal volume and the inspiratory time. If the volume falls, the airway pressure increases. If the volume increases, airway pressure decreases. This is PRVC. It just shows you how it adjusts pressure to achieve different tidal volumes. So if you want higher tidal volumes, it will titrate pressure in a higher way. These are the other names of APC, which I already talked about. So far, we talked about ventilation modes, and then we're talking about breath types. And breath types, I spoke about volume control, pressure control, adaptive pressure control. Now I'll talk about pressure support. So similar to pressure control, pressure support provides a set pressure support above PEEP level. So you can say, for example, I'm giving PEEP of 5 and pressure support of 6. So it will be 6 above 5. But unlike the pressure control, you cannot set inspiratory time with pressure support. You can only say how much pressure support you want to give, and you can say when you want the inspiratory time to end. Excuse me. You can only set your pressure support, and you can set when the inspiratory time will end, or the cycling. So if we look here at this graph, it's important for you to see that here we have the first one, we have airway pressure, and the second one is airflow against time. So on most pressure support modes or breath types will cycle off, like the inspiration will end. So when I say cycling, cycling means the end of inspiration and the beginning of expiration. This is cycling. It will cycle at 25% of maximum inspiratory flow. So you are breathing in, pressure is going up, flow is going up, and then once the flow starts falling down to 25% of the peak, the ventilator will cycle off, and this is the end of inspiration. So if you say, I want it to cycle off at 5%, this means that you will prolong the inspiration. If you let it cycle at 50%, you will shorten the inspiration. So that's your only way with pressure support to decrease the inspiratory breath, the inspiration time, or increase the inspiration time. And you adjust the pressure support, but you cannot specify number of breaths per minute. So typically pressure support is combined with spontaneous mode of ventilation. And the patient will breathe spontaneously, and when they are taking a breath, they get a pressure support to help them. The patient effort will control the rate. The patient will decide to breathe 5 times per minute, 50 times per minute, 15 times per minute. They will decide that, not you. They will decide their inspiratory time, the flow, and the tidal volume. If the patient generates minimal effort, like this patient in panel A, for example, they will have a small volume. If the patient here decides to add more inspiratory power, because remember, these are awake patients, so they can add their own muscle power to the pressure that you are giving them and generate bigger flows and bigger volumes for longer periods of time. So they can increase their flow, they can increase their volume, breathe faster, and that's dependent on their effort and respiratory drive. So pressure support summary, it's pressure set, it's volume and flow variable, it's flow cycled, and you can combine it with SIMV or spontaneous mode. So I think, I'm sure that many of you are asking themselves the question, so should I use volume control or pressure control? And this question is very common everywhere. Some people live with volume control because they feel that they were trained to do that and they are comfortable with it. The staff around them are comfortable with it. Some people use pressure control for the same reasons. So is there real advantage of one over the other? Let me tell you that there is no solid evidence that outcomes in the patient will be better in one over the other. So do what you are comfortable with, volume control or pressure control. But let me show you some advantages and some disadvantages. So in general, you have to know that volume control favors control of ventilation and pressure control favors control of oxygenation. So if you have a clinical situation where you want to control how much tidal volume the patient is getting in a guaranteed way, use volume control. If you have a situation where a longer inspiratory time, higher mean airway pressure is more favored, and oxygenation control is more favored, use pressure control. Volume and pressure control modes have advantages and disadvantages related to flow and pressure patterns. So let's start with volume control. What's the advantage of volume control? As I said many times, you have guaranteed tidal volume, producing more stable minute volume. For example, ARDS, most studies, like the famous trial, ARMA trial, that showed benefit of low tidal volume, 6 mils per kilogram of ideal body weight, came from volume control studies. Patients were not on pressure control, they were on volume control. And that's why if you want to make sure your patients are getting 6 mils per kilogram, you should go with volume control. But if you can follow the patient on pressure control and make sure that their volume is around 6, you can do that as well. Asthma patients, for example. So when you start an asthmatic, like if they are on pressure control, you may drift into a dangerous situation. So for example, a patient is very asthmatic, very obstructive in their lung, and you start them on pressure control, and you will have to go to high pressure, driving pressure to achieve a reasonable tidal volume. But then after the lungs start opening up, after the airway starts opening up, the same pressure that you are giving them at the beginning of their asthma exacerbation will generate a much bigger volume as their asthma starts improving because their airway resistance is decreasing. Now with volume control, you don't have this problem in asthma because you are giving the same volume and you are controlling the volume. With pressure control, it can change with time. The other issue is the initial, with volume control, the initial flow rate is lower than in pressure controlled modes, thus avoiding high resistance related early pressure like in asthma. So here, for example, look at the pressure. The pressure goes up gradually with volume control. Look in pressure control, the pressure goes up suddenly. This sudden rise in pressure, as opposed to this one in volume control, right, can have these effects. So the flow rate is lower than in pressure control modes. And also look at the flow, look at the flow here in pressure control. You see how the flow starts very aggressively here. This rapid rise in flow can be problematic in some patients like asthma and COPD because it can violate the pressure limits. It can increase your pressure significantly. So what are the disadvantages of volume control? The first disadvantage of volume control is what I said. Because with volume control, the mean airway pressure is lower compared to pressure control. It may be less favored in patients with oxygenation problems. How do I know that mean airway pressure is lower? Look at the pressure time curve in this volume control. This area, look at this area here and compare it to this area here. This is a perfect square. The area under the pressure curve and pressure control is bigger than the area under the semi-rectangular, semi-triangular shaped pressure time curve and volume control. So you know that mean airway pressure is higher in pressure control on average. The recruitment might be poorer in volume control. That's the other disadvantage because the pressure peaks later, not earlier. And in pressure control, the pressure peaks earlier. In volume control, the pressure peaks later. Also, if you have an air leak issue like bronchopleural fistula or chest tube, the leak will be more difficult to live with in volume control. In volume control, you will lose your volumes with air leak, but in pressure control, it can adapt with air leak in a better way than volume control. However, some people argue that if you use a decelerating waveform, many of these disadvantages will disappear. If you use a decelerating waveform, the mean airway pressure will increase with volume control. The recruitment will be better of the lung, and it will be better adapted to deal with a leak. So you can use volume control in a decelerating waveform and make it look more like pressure control. Now, what are the advantages of pressure control? The increase in mean airway pressure. As I said, there's bigger area under the pressure curve, making the oxygenation better. Increased duration of alveolar recruitment. So all the disadvantages of volume control are advantages in pressure control. It is protective against barotrauma because you know how much pressure you are giving and you will not exceed that pressure. Patients are generally more comfortable on pressure control than volume control because patients like this feeling of sudden rise and flow at the beginning of inspiration. This gives them comfort, and those who have air hunger will be happier with pressure control. The disadvantage with pressure control is the tidal volume is very variable and dependent on respiratory compliance. As I said, if your compliance or resistance changes on pressure control, the delivered volume will change. The uncontrolled volume may result in volutrauma. So you protect against barotrauma, but you do not protect against volutrauma with pressure control because you may exceed volumes with pressure control if you are not watching the patient. So how do we solve this problem? So maybe some people have been advocating for adaptive pressure control or PRVC, pressure regulated volume control. So this mode, it combines advantages of pressure and volume control modes without the disadvantages. It guarantees that you will give the right appropriate volume for the patient while maintaining a square pressure waveform like a pressure control. So the recruitment will be better, the mean airway pressure will be better, oxygenation will be better while you are not violating the volume. However, don't get me wrong, sometimes adaptive pressure control or PRVC can have disadvantages. I've said that the ventilator will titrate the pressure control to the tidal volume. If the patient starts working up and starts like breathing actively, the ventilator will sense that the patient is getting the tidal volume that is required. So the ventilator will automatically decrease the pressure control, which can result in fatiguing the patient sometimes. So final section of this big lecture is how do you write a ventilation orders in a critically ill patient. So here I will show you my own suggestions of writing a prescription, not necessarily the right way, but the one that most of us do. So in a critically ill patient, you should start with a CMV mode or the assist control mode. Don't use SIMV. Don't use pressure support when someone is coming in critical illness. You should not put them in a spontaneous mode, pressure support, SIMV. You should put them in a relaxing mode. So CMV mode or assist control mode is the recommended one. It guarantees a clinician set number of mechanical breaths. It allows the patient to control the total respiratory rate, and it requires very little patient inspiratory effort and work of breathing. After you choose your mode of ventilation, then you can choose the type of mechanical breath. You can choose volume control, pressure control, or adaptive pressure control. Now, if you are comfortable with pressure control, you can use it. But because most of our patients...
I didn't get that. Could you try again?
Sorry, that's acting up on me. Okay. So with volume control, however, we use it because most of our patients are ARDS patients and we like to control the volume we give them. So we can, I urge you or recommend that you can use volume control, or you can use adaptive pressure control breaths. So volume control or PRVC. And this is an example of other settings. For tidal volume, if the patient has no ARDS, then you can give them about 8 mils per kilogram of ideal body weight. If they have ARDS, you should go with 4 to 6 mils per kilogram of ideal body weight. Peak inspiratory flow, anywhere from 60 to 80 liters per minute. Flow profile, you can use descending or square. As I explained to you, the descending waveform has better oxygenation and longer inspiration time. The square waveform has shorter inspiration time. And if you are given the choice to pick the inspiration time, you can pick around 0.6 to 0.8 seconds. If you pick adaptive pressure control, you choose the tidal volume same as volume control, and the inspiratory time same as volume control. And then you have to specify your FiO2. When you first intubate a patient, your FiO2 should be 1.0 or 100%. And then you do a blood gas or you follow oxygen saturation on the monitor and go down on the FiO2 gradually until you are preferably below 60% FiO2, if you can. In patients with acute or acute on chronic hypercapnia, like a COPD exacerbation, because the main problem is ventilation, not oxygenation, you may start with FiO2 of 0.5 or 0.6. The respiratory rate, we usually for most patients, it's 10 to 14 breaths per minute. If someone is chronic COPDer, then we don't want to wash CO2 very quickly. And you will go with 6 to 10 breaths per minute, and then you can check a blood gas 1 hour after intubation and adjust. PEEP is used to keep the atelectatic alveoli open and to improve the PaO2. PEEP is very important in recruitment. And I think Dr. Mohsen and Mr. Dam will speak with you about recruitment maneuvers, and they will probably mention that. We usually start with a PEEP of 5, and you can go up all the way to 10 or 15, depending on oxygenation parameters and certain other measurements that other speakers will mention to you. Finally, there is the trigger type. So I've said that the ventilator will initiate breaths on its own, but if the patient wants to initiate their own breaths, like spontaneous breaths, then there are 2 types of triggering. There's a pressure trigger and there's a flow trigger. So the trigger is how the ventilator senses the patient's wish or the patient's need for a breath. So it can sense it by pressure or by flow. So a flow trigger usually is more sensitive than a pressure trigger because there is less time between the onset of patient's inspiratory effort and gas entry to the lungs. So it reduces the delay between the initiation of breath by the patient and the delivery of the breath. What's more important than what kind of trigger you use, whether it's pressure or flow, is the settings. So you can use pressure sensitivity in your ventilator, and usually we start at -1 to -2 centimeters of water pressure. Now, if your pressure sensitivity, let's say, is not sensitive, meaning that you are setting it at -4, it means that the patient will have to bring the pressure down by -4 before he receives a breath, which can be very fatiguing to the patient. So if you keep it at -1, -2, that will be more convenient. Now, if it's less than that, then the ventilator may go into auto-trigger mode. Even with the slightest effort or movement of the patient, the ventilator may sense the need for a breath. For flow sensitivity, usually we set it at 1 to 2 liters per minute. So this is an example of a complete order. A patient getting 500 mils, 0.7 second of inspiratory time, 60 liters per minute in volume control, descending flow profile, FiO2, 12 breaths per minute, 5 of PEEP, and trigger sensitivity of 1 to 2 liters per minute. And this completes your volume control CMV or adaptive pressure control CMV order. So in conclusion, there are 3 ventilation modes, 3 main ventilation modes: CMV, SIMV, and spontaneous mode. There are 3 breath types, mainly volume control, pressure control, and pressure support, and some variations in addition, like adaptive pressure control. Be familiar with the nomenclature and what you have in your unit. In critically ill patients use CMV with volume control mostly in very sick patients, and when they recover, switch them to spontaneous mode. We can talk more about that in the weaning lecture at the end of the week. And with that, I finish my lecture, and I wish to thank you for your patience, and I hope it was useful. I'm willing to take questions now or later. Thank you.
شكرا جزيلا دكتور نادر. بارك الله فيك.
You're welcome. Thank you, Dr. Muhammad.
As we said in the introduction, the mechanical ventilation is an art rather than science, and hopefully the tools of this art is now clear for the audience. I will give like 30 seconds if there is any question. If there is no, we will go for the workshop. So if anybody of the audience would like to speak or to send a question, more than welcome. Seems there is no question from the audience. Thank you very much, Dr. Nader. We are happy to have you more with us to the end if your time is available. If your time allow this, and if not, we can send you any question or we can discuss it on Thursday, inshallah.
اوكي ثانك يو فيري ماتش شكرا للجميع و اذا في اي اسئله ثانيه لو سمحتوا ابعتوها او فيدباك او اي اقتراحات ثانيه ابعتوها للدكتور قنديل and I'm happy to share with everyone. يعطيكم العافيه. السلام عليكم.
وعليكم السلام. So now let us welcome Dr. Mohsen Shaheen. He's an MICU consultant, and Mr. Damo is a senior respiratory therapist with long history of education about mechanical ventilation. They will do like a workshop about how to do a recruitment maneuver for ARDS patient, and then how to achieve or to know the optimum beep. So Dr. Mohsen, now you can share your screen, please.
Share now?
Yes.
Share now.
So we'll do the scenarios in Hamilton ventilator. We'll use most likely the volume control, pressure control, and ASV mode, which is a new mode, especially for this machine. It's good to know this mode. It's called ASV. Also, we'd like to welcome Mr. Muhammad. He's an Hamilton company representative here in Doha. If you can hear me, Mr. Muhammad. Go ahead, Dr. Mohsen.
السلام عليكم. السلام عليكم ورحمة الله. شكرا جزيلا دكتور محمد على الاستضافة، وشكرا دكتور نادر على المحاضرة القيمة. إن شاء الله اليوم we'll discuss some scenarios وإن شاء الله تكون مفيدة للجميع إن شاء الله بإذن الله. هيكون معاي مستر دامو. He's one of the experts in his field and he's a senior respiratory specialist. إن شاء الله we will go for 3 scenarios and هنحاول نسوي تطبيق عملي على الهاملتون. وطبعا انا عارف ان الهاملتون مش موجود بس موجود ريجرز، بس ان شاء الله هنحاول ناخذ الاشياء الكومون يعني between 2 ventilators ان شاء الله. فالكيس الاولى so Mr. Ibrahim, he's a 56 years old. He's diabetic hypertensive. He was admitted to our ICU with the shock and hypoxic respiratory failure, diagnosed with COVID-19. Now he's intubated, ventilated, sedated, and started on noradrenaline. His height is 175. His actual body weight is 85. And as you know, we are in mechanical ventilator. We are dealing with the ideal body weight. We are not dealing with actual body weight. So we have like calculation, and it's and we can share it with you even like tables. So according to his height, the ideal body weight is 69 kilograms. This is his X-ray. As we see, this bilateral infiltrate and goes with ARDS. So Hamilton here, it's here. Yeah. On me. PowerPoint. طلعها شنو؟ اوكي. هذا تعدام. Some meeting. Okay. Share screen. It's okay now. Okay. نعيد من الأول. Okay, لا نعيد من الأول. Yeah. Okay. So according to our patient, Mr. Ibrahim, this is his initial ABG immediately after intubation. He's an FI 280. His pH 7.2. His PO2 is 60. BCO2 58 with bicarb 20. So if we calculate the BF ratio, which is 60 divided by 0.8, which will be 75. Let's go with severe ARDS. Anything BF ratio below 100, it's severe ARDS. So as Dr. Nader, he said, now we will talk about the initial ventilator settings, which is the immediately after intubation. Usually we are using the CMV mode, which is the continuous mandatory ventilation, volume control. As at the beginning, we'd like to control the volume just to avoid any like barotrauma. In ARDS, as we know, the protocol is to keep 4 to 6 ml of ideal body weight type of volume. BEEP usually will sit an ARDS in the higher, a little bit higher, 8 to 10, until we do the BEEP optimization and the recruitment. The respiratory rate usually 20 to 25 to maintain a minute ventilation. And IA ratio at the beginning, we'll put it 1 to 2, and after that, we can adjust it according to the situation. If IA2 at the beginning, we'll make it 100 just to achieve saturation above 90%. After that, we can come down and decrease. Now we will share the Hamilton, and we can see the Hamilton now. And now Mr. Damo, he will start applying the BEEP optimization and this one. Yeah. So yeah, this one. Unmute.
Thank you, Doctor. Thank you for giving the chance. Now, we are going to explain about the lung recruitment workshop. The group was a senior for Thank you. Now, the patient's ideal body weight is 70 kilograms. If you work on the scenario, okay, this is the scenario. Several ventilators, many ventilators are using, but we are going to demonstrate one of the equipments that we work on it. The simulation will work on the control mode, assist control mode. Okay. Now we are going to set a volume control mode of ventilation. Now the patient showing the high PC mode to cardiac level. 70 kilogram patient, normally we used to give 4 to 6 ml ideal body weight. As if earlier, Dr. Marcus explained, the earlier patient 4 to 6 ml ideal body weight. And that's a 70 kilogram patient, multiplied by 6, around 420 ml we are going to give the patient. You make it 420, patient is showing higher. Initially, Dr. Mawson told make it 100% oxygenation. We make it 100%. Yes, done. Still, patient descending, the patient PCO is high. Dr. Mawson said we'll make it 20 to 30, 25 to 30 blood per minute. We'll make it 25 blood rate. And you make it cancel because still the ST was lower. We make it again the P. Still the patient selection argument compliance is 11.1. This is all the year situation university and basic systems, only the compensation. Since there is a situation where what can be the next step for us? We increase the level to 100 to 10 centimeter water pressure. Still the saturation is 74 only. The next step we have to go for the lump maneuver. Immediately we have to work on it. What is the lump maneuver? The lump maneuver is sustained to increase the airway pressure with the goal to overcome collapse of the level. Often it's sufficiently supplied to keep the lungs open. The goals of the regulatory maneuver are served as part of lung protective strategy and moreover improve oxygenation. But the different hospitals, different maneuvers are used because of the clinician recommendation, clinician trained. And the three-way method normally we used to do is what we call a single pressure recruitment. That's the 40 centimeters by 40 seconds. The another method they used to test stair-based measurement. That's called incremental beat. 10, 20, 25, 30, 30 to 40. Then they will go down these type of things. The third method, some new generation ventilators are available. Protective ventilation tool. That if we don't have the ventilation, we will go for the single pressure maneuver and stair-based maneuver. Doing the maneuver, if any good balance instability, the equipment can be stopped and then we can focus on treating the patient. Once it's a successful maneuver, the setting appropriately is called decompensation. The decompensation is static compliance, thus due to the patient oxygenation. Now, you do single pressure recruitment, you know, since it goes along the same path of the test.
Okay, continue.
We will increase the heat to 40 for 40 seconds. That's along the peak current pressure and plateau pressure is going up. And then they explain, another explain what's the peak current pressure, plateau pressure. If the plateau pressure exceeds more than 10 to 15 the patient is having the ERDS. The plateau pressure on the at the end of instillation, there is no pressure. That pressure called as a plateau pressure. Normally, ERDS recommendation explain to us less than 30 centimeter water pressure. But then we should go further to 6 ml ideal body weight. That's already what Nader explained in the previous session. We will go for the pressure maneuver in these settings and make it 40 centimeter pressure for 30 seconds. Because of this simulation doesn't have 40 centimeter water pressure, maximum 25 ml available. I go to the 20 centimeter water pressure for 25 seconds. This is the saturation and compliance. The compliance was 11 before, now 24 increased, 27. Saturation was 71, now 85 is increasing. This is what I look at the initial institute. The another method we will follow. You will go back to the heat. This is called gas. incremental peak, we will go down to 10, the baseline was set before perfect incubation. Unless the saturation cannot now, this is when they used to go around 15 centimeter pressure for 2 to 3 minutes. In the meantime, they will assess the patient saturation and static compliance whether improving or not. After 2 minutes, we get to the peak, we will increase to 20 for 2 to 3 minutes. And we will observe there is no hemodynamic instability. In between the recruitment, we need to know the recruitment can stop.
Actually, very low.
Now, okay. Now,
ابدا انا على السريع في اوكي سو اعطيهم على السريع.
We are very sorry. We'll start again. I think there is Mr. Dam was
Okay, you can speak now.
sorry for disturbance. There was some technical issue. Okay. We saw the patient peak pressure going up and plateau pressure going up. Already Dr. Nader explained all the things. We will not repeat it again. Since the patient severe ERD, desaturated, compliance is decreasing, this situation already the peak of 10 initially beginning scenario and 100% oxygenation patients getting. The main objective to improve the oxygen. We have to the patient recruitment maneuver. The recruitment means the recruitment maneuver is sustain increase in airway pressure with the goal to open the alveolar collapse. Sufficient PEEP is applied to keep the lungs open. The goal of the recruitment maneuver are to help a part of lung protective strategy plus improvement of oxygenation.
take this laptop. Go ahead.
There are several methods available. The lung recruitment method based on the clinician trained or comfortable zone. There is a 3 recruitment maneuver available. That's calling a single pressure maneuver. That usually the clinician recommends 40 centimeter per peak for 40 seconds. Some clinician will go for the staircase maneuver, that's called the PEEP, incremental PEEP, up to 40 centimeters. Gradually, they'll go 10, 15, 20, 25, 30, 40. Then followed by PEEP harmonization to fix the PEEP, which PEEP is the patient suitable based on the patient static compliance and saturation, other hemodynamic stability. At the same time, during the maneuver, the clinician should observe the monitor any hemodynamic instability. The recruitment can be stopped and treat the patient primary causes of what's going on. A successful recruitment maneuver followed by an appropriate PEEP setting is associated with increased static compliance as well as improvement of oxygenation. Now, We said single pressure maneuver. We'll go with the PEEP to 40 centimeter PEEP. But this scenario, this workshop, we don't have maximum 40. We have only 25 centimeter water pressure. We'll give 25 centimeter water pressure for 25 seconds. So we see the saturation and compliance. The PEEP we can monitor in the bedside monitor. We increase the 25 centimeter water pressure for 25 seconds. You can see the saturation is improving and the compliance is improving. When the 25 seconds finished, go back to your previous baseline PEEP, avoid the over suspension for long time. Some patients will go for the staircase maneuver, that's called as incremental PEEP. Since already increased the saturation and static compliance, we'll restart how to work on the staircase maneuver. We'll go slowly the PEEP to increase 15 centimeter water pressure for 2 to 3 minutes. In the meantime, we will observe patient's all unit stability plus saturation followed by static compliance. When the 2 to 3 minutes, the patients maintain all vitals are stable, we'll go to 20 centimeter water pressure of the PEEP. Again, we need to assess the patient hemodynamic stability. You can see the saturation gradually improving and static compliance also improving. Make sure the PEEP is maintaining. Once 2 to 3 minutes finished, we can go back, we can go to again increase to 25. Assess for the patient, the same thing, hemodynamic stability. Now saturation came to 92%, somewhat usually the ARDS patient, 92 and above the target saturation. Now static compliance came to 31 centimeter water pressure. So sorry, ml centimeter water pressure. Now that's good improvement. But this scenario, this here, we cannot go for the more than 25 centimeter water pressure. So this is the incremental PEEP, followed by, once done recruitment, we have to work on the PEEP optimization. For the PEEP optimization, we'll work later on another scenario. Now we'll go back to the previous set of PEEP of 10 centimeter water pressure. Now the other method, most of the advanced ventilator, the latest generation ventilator is available of the protective ventilation tool, that's called the PV tool. We'll work on the PV tool. The PV tool usually they're calling us 2 maneuvers. One is the make sure diagnostic and the recruitment maneuver, 2 things available. Even though if we don't have the equipments with us, we will take the knowledge. In future, if we get the equipment, we'll work on it. It's available PV tool. Click the PV tool. Make sure before the recruitment, either single pressure or staircase or the PV tool, always make sure that the cuff is fully inflated, patient sedated or paralyzed with the paralyzed. Moreover, suction should be done oral and ATT period. So all the things done. So I'm confirming now this one. This option now is not working here. I'm trying to work on it. Just a few seconds.
So then we can skip the BB2.
Yeah.
Because just now the voice is here, and we can repeat the recording.
Okay.
Just say the result.
I'll go with the PEEP optimization now.
Yeah, people transition the recording.
Yeah.
No need for BB2.
Thank you. Thank you, Dr. Kandil. The PV tool will not work on it. Only that other ventilators available. Since if you don't have equipments, PV tool, we can go for the staircase recruitment on single pressure maneuver or MNO. This we can do. Already we recruited the patient. PEEP to 25 we mentioned. So we'll wait for a few minutes. The saturation, other things will improve. Once the saturation comes to 92 and above, we'll go for the PEEP optimization. The PEEP optimization, usually they used to do the decremental of PEEP, either 2 to 3 centimeter water pressure. They gradually assess the patient. The saturation drops 1 or 2% down from the maximum saturation. That's the PEEP is calling as optimizing PEEP. That we will work on it. We will wait for a few seconds. The saturation will improve, and then step by step we will work on it. 93, compliance improved. 33. Saturation coming up to 94. It's 95. That's good. We'll see what's the ABG now. Analyze. ABG now 77%, 77 mmHg, PCO2 is 44. More than 60, 65 for the PaO2 acceptable. The saturation came to 96 now. Now the time to do for the PEEP optimization, giving longer time for the PEEP of 25, the patient may develop barotrauma. During the PEEP optimization, our aim usually ARD is 92 and above saturation. It's already 97. We'll minimize the oxygenation, gradually go by the 10% higher, lower, sorry. We'll assess for a few seconds. If the saturation drops or not, we'll work on it. It's still 97 maintaining. So we'll go down further down to bring to back to 92% of the saturation. I'll go to 80. Percentage. From 97 to 96 came, the saturation 96, compliance still maintaining the same. So I wanted to go further down of the FiO2 to 70%. We'll see the saturation came 95. Make sure the patient's hemodynamic stability. So I want to go further down to 92%. I'll go to 50%, we'll see. $94 came now. Hopefully we're expecting the 94 down, yes, 93. We'll keep it 50 for FiO2. We will work on the PEEP now. Gradually we'll go down the PEEP of 5 centimeter, reduce the 5 centimeter of PEEP. Assess for the same thing, hemodynamic stability, saturation, and compliance. Compliance saturation maintaining 92, and compliance 33.5 maintaining acceptable, but saturation dropped to 91. So the PEEP we have to increase to a little bit higher. We'll assess for a few seconds, 92. I make it 22 PEEP. Normally, if you do PEEP recruitment, this is a what they call simulation. We will not get correct optimization of PEEP. Normally, we used to get our experience PEEP from 15 to 18 centimeter. We used to get most of the patient optimization. This is the simulation. We are not getting the accurate value. So the PEEP 22, the saturation around 91. So acceptable the situation, the PEEP, we can optimize the PEEP of 22 centimeter water pressure for this one. Normally, any patients, most of the patients, the PEEP optimization, we are getting around 15 to 18 centimeter water pressure. Since the simulation is worked with the 22 PEEP and 91 saturation. Okay. We have done so far single pressure maneuver, staircase recruitment, PEEP optimization. The PV tool, we are not going to work on it. Can we proceed another maneuver? ARDS non-recruitable, doctor?
So just
You can brief. Okay, go ahead. Dr. Mosen will give some brief instruction.
Okay.
بسم الله الرحمن الرحيم. احنا متاسفين جدا على اللي صار بالنسبه لتردد الصوت وصدى الصوت. حنخلي الدكتور محسن يعطي بريف هلقيته، بعد هيك بالدسكشن انا حابب منكم تسالوا اي واحد عنده سؤال او استفسار، او اذا بده يعيد اي ريكروتمنت، نعيد ريكروتمنت او نعيد البيب اوبتمايزيشن. Just feel free to send the question because this is a workshop. This is not a lecture. Dr. Mohsen is speaking now. دكتور محسن go ahead. Just now.
فبالنسبه لنا الحين هنستارت يعني نلخص المستر دام الكامل قالوا. In our patient, his ideal body weight was around 70 multiplied by 4. We'll say that his ideal body weight was 70. Let's say from 4 to 6 according to the tidal volume and peak pressure. So now we will start with 6. We'll say 420, and we can see the peak pressure. His peak pressure was high, so even we can go. We can go. Yes. No, it's okay. Okay. زي ما احنا شايفين بدينا ب 6 ml بير 6 ml بير كيلوغرام ايدل بادي ويت، اللي هي حتطلع 420 and we will look at the peak pressure. Peak pressure 45, which is this is very high and يكون في ريسك big risk of باروتروما، وممكن ندخل في النيموثوراكس او حتى يعني نيوميرساينم. فالبيست ثينج طبعا اوكي خلينا نلخص من اول نبداها. الحين بدينا على this patient. اوكي ف 420 اذا شفنا انه البيك بريشر از هاي، طبعا احنا الحين بعد ما نزلنا البيب ل 10 البيك بريشر واز يعني بيتر 41 42. So in this case ممكن ننزل في التايدال فوليوم ل 4 to 6 4 to 6 fall 4 multiplied by 70 to 80. فاحنا ممكن حتى ننزل كمان اكثر، نروح ل 380. وطبعا لازم يكون ميت فولي سيديتد فولي بارالايزد، هذا يفضل طبعا في البدايه. البيب 10 just to achieve saturation as we said 90% او اكثر. طبعا في الانيشال احنا نرفع الساتوريشن ل 100% على اساس زي ما حكينا تشيف 90% او اكثر. الحين after that we will go for the lung recruitment. lung recruitment في اكثر من مانوفر. في first maneuver as Mr. Damo said we have the single maneuver, we have the staircase يعني نطلع بالتدريج slowly. وفي الادفانس البي 2. طبعا البي 2 ما راح نتكلم عنه، راح نتكلم مع initially مع اللي هو السنجل مانوفر. single maneuver which is very easy and can be used on every ventilator. Just we will keep the beep 40. بس طبعا للاسف in this simulator الماكسيمم is 25 but you can go to 40 for 20 to 40 seconds. طبعا provided that the vital stable patient is not severely hypotensive, because you know increasing the beep will make a patient more hypotensive. So we'll make it like 40 for 20 to 40 seconds, and after that we will watch the saturation. لاحظوا معي انه طبعا الحين الساتوريشن قاعد يتحسن 89. طبعا هذا يعطينا indication if the saturation تحسن، يعطينا indication that the lung is recruitable lung. That means that يعني the lung compliance is not bad. طبعا في امثله لاحظوا انه الساتوريشن تحسن تحسن. في الحاله هذه now we will go to beep optimization. هذا احنا اول شيء عملنا اللي هو lung recruitment. Now beep optimization that now احنا الحين رفعنا we will set the beep 25 او 20. خلينا الحين على 25. After that we'll go slowly every 2 minutes by 2. يعني مثلا نروح مثلا نفترض 22 نقعد 2 minutes in each one 22 and we will look at the lung compliance الستيك اللي هو 33. We will look at the oxygen saturation and we will look at one other vital signs. نسجلهم every 2 minutes we will go down. Now this is 22. After suppose that 2 minutes over we'll go further to 20. and we will look at the lung compliance. كانت 33.7 now. ونشوف الساتوريشن. After 2 minutes, 2 minutes is over. We'll go further by 2. Now it's 18. And we'll write it down. Each one we'll write them how much the beep, how much the lung compliance, saturation, and the vital signs, usually the blood pressure. It was 33, now 34, so it's better. And now we'll go to 16. نشوف كيف الستاتيك لانج كومبلاينس صارت. 34, 33.8. Now we will wait for 2 minutes in each step. لا شوف نزلوا 32 32.4 طبعا اوكي. خلينا ننزل كمان وحده مور نروح ل 14 we'll see what will happen. لاحظين اللانج كومبلاينس is down coming to 29 حتى الساتوريشن كان 97 95. فلو هنشوف حسب المكتوب طبعا حيكون افضل حسب ما شفناه حاليا in this patient كان افضل optimal beep was 18. This is what called the optimal beep for this patient. فزي ما حكينا ملخص اول شيء نسوي لانج ريكروتمنت. عاده اسهل طريقه والافيلبل اللي هي السنجل مانوفر. put the patient beep 40 for 20 to 40 seconds. طبعا provided انه vital stable ما يكون severely hypotensive. وبعدين if the oxygenation تحسن والامور تحسنت معناها this is يعطينا good indication that the patient is the lung is recruitable lung. And after that we will go for the to see what's the optimal beep. Optimal beep, the best way to do the optimal beep is then, as Mr. Damo said, the staircase. That means نبدأ في 22 ننزل 20 each 2 minutes 2 to 2 and we will write it down. وبعدين نقارن which was the best oxygen saturation and the best lung compliance and this will be the optimal lung beep. Yeah. فطبعا في ادفانس تولز البي في تولز طبعا هذا تكون من البدايه هذه موجوده طبعا فيري ادفانس فنتليترز تعطيك من البدايه حسب اللانج كيرفز والفوليومز. طبعا احنا نتكلم الحين حاليا نتكلم على شيء عملي. يعني الشيء العملي حاليا اللي هو زي ما حكينا انه ويل جو فور ذا single lung recruitment. After that we will see if the with the lung recruitment تحسنت الاكسجينيشن هذا يعطينا strong indication ان اللنج is recruitable. طبعا هذه ممكن الحين يعني هذا الفيرست سيناريو. نيجي للسكند سيناريو اللي هو ممكن حاليا نوريكم اللي هو النكست سيناريو. اوكي النكست سيناريو will be لحظه شوي بس. النكست سيناريو حيكون اوكي
دكتور محسن
next scenario will be
this is طبعا workshop we will ask some of the audience at the end about like to do recruitment, to do like you will set scenario at the end and then I will ask one of the audience to do like recruitment and then the other one to do beep optimization to make sure that it is
second scenario now. As we said, we will usually use the CMV mode.
دكتور محسن share the
initial settings زي ما اتفقنا ان usually will keep 20 to 25 initial 25. tidal volume the patient كان وزنه 70 will start from 4 to 6 then it will be 420 نحط initially. beep, let's start with 10 beep at the beginning. Okay. بعدين initially نحط الأكسجين نخليها 100%. Usually the I ratio initially we'll keep it 1 to 2. One to 2. Okay, and confirm. طبعا we'll see.
Dr. Mohsen, can you share the ventilator screen? Is not shown.
It's not showing. Okay.
Yeah, share it. Yes.
That's the okay. طبعا الالارم بس احنا بس نرفع الالارم عشان يصير الازعاج شويه. So let's do the lung recruitment here. Okay. The same thing, the previously recommended lung recruitment, either single pressure or staircase recruitment, we'll do now. Again, repeating, this patient make sure the lung is recruitable or not. This we'll make it 25 centimeter water pressure, normally 40 centimeter, but since the simulation is only 25, we go with 25 centimeter water pressure for 25 seconds. Observe the patient hemodynamic stability. The patient eye pressure going because the PEEP is increased to 25, the total pressure going to 69 and 84. For 25 seconds, we go back to the previous PEEP. Almost 25 seconds, think about assume kind of completed. We'll go back to 20 baseline PEEP of 10. We want to see it now. The saturation improved. The compliance is still not getting up. We'll see the ABG also going on. Issue almost less than 150 going on. So this situation, the patient, patient considered is not recruitable. Since the patient's not recruitable, we will not proceed for the further process of recruitment. The option next treatment for the patient, since the patient's not recruitable lung, we'll work on the patient's 100% FiO2, maximum PEEP of 10 centimeter water pressure, followed by, we'll start another therapeutic measurement, the patient will go to prone positioning. The prone positioning, the two types they will do. Some people, they have rota bed. Some hospital center, they have the manual proning. Whereas Ahmed Medical Corporation, we are doing the manual proning. 3+3 people with a doctor and therapist will be provided. The therapist will take care of the head position. Doctor will stand by for the any intubation, any hemodynamic stability. Followed by the nurses, 3 nurses, and the other side 3 nurses, 10 nurses. We will do proning for the patient. The advantage of the proning for the manual proning, any patient unstable, we can see easily all the lines. Easily we can treat the patient. If you want to do lung recruitment, even you do on prone positioning. Whereas a rota bed need the person fully trained. If any disturbance of the rota bed, difficult to get back to normal position, all the areas are disturbed with the patient, difficult to find out the lines, other things. Always we prefer the patient will go for the manual proning. Still, manual proning, the ABG is comfortable, around 10 to 20 mmHg PF ratio improved. That means effect of the proning. Otherwise, we used to apply for the patient inhaled nitric oxide. Still, inhaled nitric oxide, the patient is not getting improved. The final chance will go for the VV ECMO for the patient.
Okay. So يعني شكرا ثانك يو مستر دامو. ف يعني ملخص طبعا هو احنا عارفين مرات تكون صعبه انه تشير السكرين وحتكون يعني بس احنا حنحاول قد ما نقدر انه في حاله زي ما اتفقنا انه usually we'll start any RDS patient will start with lung protective strategy هم زي ما اتفقنا عليهم نعيدها مره ثانيه 4 to 6 ml per radial body weight. البيب initially make it 8 to 10 respiratory rate من 20 ل 25 just to keep minute ventilation to wash us CO2. اول ما نحط المريض initially he will be should be sedated paralyzed initially, especially لو كان على FI2 more than 60 and sedated paralyzed for the first time. نبدا في اول شيء lung recruitment زي ما حكينا. البيست واي والسنجل واي نحط بيب 40 for 20 to 40 seconds ونشوف الريسبونس. If the response is good and the oxygenation start to improve after 40 seconds, this good indicator يعطينا مؤشر ممتاز ان the lung is recruitable. recruitable حنروح لموضوع البيب اوبتمايزيشن، ان نشوف ايش البيست بيب للمريض. نبدا عاده ب 20 ننزل زي ما حكينا، انا اعيد مره ثانيه ملخص 20 ننزل 2 by 2 every 2 minutes. نسجل اللاين كومبلاينس، اذا كانت اللاين كومبلاينس موجوده في الجهاز بتطلع دايركتلي كويس، اذا مش كويس ممكن نحسبها. اللاين كومبلاينس هي تايدال فوليوم اكزيت تايدال فوليوم تقسيم الدلتا بيب اللي هو البلاتو ناقص البيب، ممكن نحسبها ونسجلها ونسوي زي التيبل ونشوف ايش افضل كومبلاينس مع افضل ساتوريشن. هذا حيعطينا انديكيشن ذيس از ذا اوبتيمال بيب لهذا المريض. لكن اذا كان المريض للاسف بعد ما سوينا اذا مريض اخر وسوينا اللانج ريكروتمنت اللي هي ال 40 بيب ل 40 سكندز وما كان في امبروفمنت، هذا للاسف يعطيك clear indication that the lung is very stiff and يعني almost not recruitable lung. في الحاله هذه just will try to minimize the beep 8 to 10 just to avoid when lung is very stiff, just to avoid any barotrauma. 8 to 10 will be okay. وهنروح ل extra maneuver اللي هو زي ما حكينا المستر دامو حكى انه we'll go for browning. احنا تكلمنا في البرونينج، طبعا معظم المرضى بيتحسنوا على البرونينج they will improve with the browning. Usually the protocol is 16 hours and can be repeated. بعض الحالات اذا كانت سيفيرلي كمان هايبوكسيك حتى على البرونينج we can go for nitric oxide، ممكن نستخدم nitric oxide in some people. طبعا واذا ما تحسن في الادفانس اللي هو طبعا الاكمو اللي هو طبعا مش متوفر في كل مكان، بس هذه هي الستبس يعني. فيوجوالي هذه الخطوات اللي بنسويها اهم شيء بركز عليها نقطتين. الابروش الاول اللي هو اللانج ريكروتمنت، نحاول نفتح الالفولاي، نحاول نحسن الاكسجينيشن از ريسك بلان. بعد هذا اذا تحسنت ويل جو فور اوبتيمال بيب، اذا ما تحسنت للاسف هذا بيكون اللانج نون ريكروتبل، وبنحاول في الحاله هذه بنروح للبرونينج نيتريك اوكسايد والادفانس ميجرز. هذه كملخص. انا عارف ان الوضع طبعا افضل شيء يكون هاندز اون، لكن يعني قلت لك يعني هذا هو نقدر يعني حاليا متوفر، وان شاء الله خير. و now for Mr. Damo. You want to add something?
Yes, Dr. Mohsen said that the proning can be continued maximum 16 hours one sitting. And after that, make sure that there is no pressure ulcer for the patient. After 16 hours, the patient can go to supine position. Wait for another 48 hours. The patient still that PaO2 is not improving, oxygenation not improving. Again, you can go for another proning session. One more sitting, that's calling as 16 hours. You can do that. Continue 3-4 times as much as you can until you get the oxygenation. Otherwise, still not effective. That's an expensive procedure. The calling as a VV ECMO that can be considered. The hospital there as if they have the facility. I think it's okay now. Can we proceed another scenario, doctor?
Okay.
Any questions?
So دكتور قنديل كلمني لما he will do now scenarios، فاحنا waiting لدكتور قنديل ايش حاب بالضبط يسوي.
Now I will give the talk to Mr. Muhammad Nabil.
Okay. Yeah.
He will give short talk, then we'll do two scenario, the same scenario actually, we will not do different. The first scenario, we'll choose 2 doctors working in ICU in Palestine. The second scenario, also another 2 doctors, and we'll ask them about the step to make sure that it's clear for everybody to do this.
That's good.
Okay.
Yeah, I will now give the talk to Mr. Muhammad Nabil. Just 1 minute, I will unmute him. Just wait, Dr. Muhammad, Mr. Muhammad. Yes.
Assalamu alaikum.
وعليكم السلام ورحمة الله.
Barakallah Fiqh, Doctor, and thank you so much for your kind invitation, Dr. Mohsen and Mr. Damo. And I hope that, inshallah, this lecture will be useful for everybody. So I'm here not to talk about a specific ventilator. I am here, I don't have any conflict of interest in this lecture. So I just want to share with you my experience with different models of ventilators in my 10 years experience in selling ventilator in Middle East. So what Dr. Mohsen and Mr. Damo was talking about is the lung recruitment. And actually, to think about the lung recruitability is a big figure, and it's a very hot topic nowadays. And please don't wait too much. I mean, if you wait for something like 72 hours, and then you try to make a lung recruitment, you will lose something like 50% of doing lung recruitability for your patient. So please, while you are intubate your patient, you should start to think about doing lung recruitability for your patient. So this is my first point that I want to highlight. The second point, as Dr. Mohsen and Mr. Damo mentioned, by using this simple way how to do lung recruitability. And then they start to talk about doing PEEP titration or how to find the optimum PEEP. The point here that I want to share it is why we should think about finding the optimum PEEP. First of all, to decrease the PEEP, because most of the people, they will not accept to have a PEEP more than 20, just like 25 or more. And the second point, which is the most important point, is you already open some alveolus when you are doing a lung recruitment. So how you can make sure that there will not be a de-recruitability for this patient is to keep these alveolus open. And how you can keep these alveolus open? By keeping a high PEEP, the optimum PEEP for this patient. So the main target for doing optimum PEEP or optimizing PEEP is to keep the alveolus that you already opened them during the lung recruitability and to keep them open. This how you will enhance the saturation for your patient. I think this is all from my side, unless if you have any questions or any comments on my talk. I hope that I share good points with you.
Yes.
شكرا جزيلا بارك الله فيك. It was very important point actually.
Jazakallah khair.
Inshallah, we'll have you in another meeting inshallah soon.
Thank you, doctor. Wish you all the best.
Thank you very much. So now I will choose two doctors working in ICU in Palestine to do one scenario, because this is a workshop, this is not a lecture. So I would like to hear from you and to. So first, Dr. Abdurrahman Safi, I will unmute you now. Dr. Abdurrahman, can you hear me?
Yeah, I can.
Yeah, thank you very much. Also, I will unmute Dr. Majd Zatme. Dr. Majd, can you hear me?
Yes, sir.
Thank you very much. So Dr. Mohsen will lead the first scenario, just for the other audience to be, aware about the process, how to deal with the patient with the like ARDS and difficult ventilation. Dr. Mohsen, go ahead with the first scenario. Dr. Abdurrahman ودكتور مجد معك.
الو سامعيني دكتور عبد الرحمن دكتور مجد سامعيني؟
صحيح. انا سامعك
من الاول دكتور محسن.
الو دكتور عبد الرحمن دكتور مجد سامعيني؟
سامعك صحيح.
سامعين دكتور.
اوكي. خلينا نبدا في اول سيناريو زي ما حكينا. This is our patient 54 years old, diabetic hypertensive, diagnosed with COVID 4 days ago, and now he is deteriorating. صار دخل في hypoxic respiratory failure وصار دخل في septic shock. We decide to intubate the patient وطبعا ventilated وبدينا على norepinephrine small dose just to maintain blood pressure. المعطيات الموجوده عندنا انه now he just now intubated. طبعا وزنه 90 كيلو.
انا حاخذ الحد تاخذيه اقول لك كلمتك بدي اخذ.
سمعني.
انا اسف عشان مشغول شوي بشغل. الحين معك، تفضل. معك يا دكتور.
طيب فاحنا الحين نرجع. اوكي، فالمعطيات الموجوده عندنا المريض طوله 175 his ideal bed weight حوالي 70 الايديال bed weight وحاليا محطوط على الفنتليتر على حطيناه على والبي فريش تبعه 75. ايش راح نبدا حاليا؟
اول حاجه عفوا دكتور
رح نبدا بالسيتد.
اوكي
بتحط التايدال فوليوم 6 ملي بير كي جي.
حلو، يعني حيطلع كم 6؟
سعر 420
420.
طيب ممتاز. وبعدين
هنحطه له على بيب، نبدا له من 8 ل 10 اف ايتومي بالمية، ريسبيراتوري ريت من 8 ل 12.
14 ممكن.
طيب هنحط 14. طيب خلينا نشوف ايش الوضع بيصير. طيب شايفين الالارم؟ ايش عندنا الالارم طالع عندنا؟
لو ساتوريشن 86.
ايوه ايش عندنا تحت الريدنجز؟
افضل حاجه نبدا بالسيتنج. ممكن لو نبدا بالبيب نعمل الاوبتمايزيشن للبيب حسب
اول حاجه دكتور عبد الرحمن، على اساس تكون عندك اريحيه لازم نرفع الاف اي 2، لان احنا بدنا لما نشتغل نشتغل يكون عندنا اتليست ساتوريشن 90 اند اباف. فاحنا هنرفع ايش؟ هنرفع الساتوريشن، يعني نحطه حاليا، نحطه طبعا 60 مبدئيا.
ماشي.
طيب وايش كمان بعدين؟
البيب حوالي
طيب
8.
نطلع تحت الحين. البلس عندك 80 which is okay. الساتوريشن 87 88 قاعد بيتحسن شوي. الانتايب سي او 2 43 كمان معقول السي او 2 تبعه. والكلاس عنده 29 يعني نوت باد، طبعا لو بس نوت باد. طيب ايش حنروح الحين نقطه خطوه اخرى؟
نطلع على الفيتال ساينز، مريض هايبوتنشن نت هايبوتنشن.
اكزاكتلي ممتاز. ايوه
انا كنت سالتك دكتور لو المريض هايبوتنسيف ومش هنقدر نعمل الاوبتمايزيشن للبيب، ايش ممكن نعمل اذر يعني كاين لنحسن ساتوريشن في هذا الوضع؟
لا ما هو بتعتمد على تعريف الهايبوتنشن. يعني اذا كان هايبوتنشن مثلا على سمول دوز نو ادرين ارفع له اياها، فهمت كيف علي؟ نرفع نو ادرين يعني اتليست نحاول قد ما نقدر انه نرفع بلاد بريشر.
يعني نحسن البلاد بريشر عشان نقدر نشتغل على اوبتمايزيشن للبيب، صحيح؟
بالضبط.
تمام. نبدا الحين نحط احنا البيب 40 لمده 40 سكند تقريبا.
نحط من 20 ل 40.
نحط ل 40 سكند بالضبط.
طيب. للاسف هون السيموليشن
هنا 25 انت حكيت الماكسيمم عندك 25.
اعتبره 40.
حلو جدا.
طيب
لمده 20 40 سكند.
اوكي من 20 40 سكند. عينك على ايش حاليا؟
انا على البيك اهم حاجه.
البيك وعلى ايش كمان؟
وعلى الساتوريشن اتحسن ولا ما تحسن؟
وعلى ايش؟
وعلى الساتوريشن. اوكي الساتوريشن
وعلى البلد بريشر.
بلد بريشر.
وعلى البلد بريشر بالضبط.
ماشي كمان عينك عليهم. طيب
صحيح. البيك عالي شوي عندي بس الساتوريشن ما تحسن كثير، يعني 89 ضلوا زي ما هو.
واحد ما تحسن. طيب خلصنا ال 20 سكند
تقريبا.
خلصوا صح؟ طيب خلينا نرجع الحين مره ثانيه. طيب ما تحسن، ايش معناها بيعطيك انديكيشن هذا؟
ممكن
لو كومبلاينس.
بالضبط لو كومبلاينس. وعلى الاغلب حيعطينا انديكيشن انه اللانج از نوت ريكروتبل لانج للاسف.
بالضبط. ممكن نعمل برومبوزيشن.
الحين في الحاله هاي لما تكون اللانج خدنا فكره انه ما تحسن على ال 40 معناها اللانج فيري ستيف، معناها في الحاله هذه نحاول انه ننزل في البيب نخليه يعني نرجع لحوالي 8 10 8 نحطه 8. ولاحظ انه ما فالحين بنروح لايش؟ زي ما حكيت للبرومبوزيشن.
صحيح.
طيب اذا ما تحسن على البرومبوزيشن ايش في عندك اشياء ممكن تسويها؟
ما تحسن نيتريك اوكسايد.
في حاجه كمان مهمه، ممكن والمريض برون نعمل له كمان انذر ريكروتمنت، فهمت كيف علي؟ يعني نعيدها مره ثانيه. هي 40
عيدها مره ثانيه. هو برضه على البرومبوزيشن.
لانه في بعض المرضى على البرون بيتحسنوا مع الريكروتمنت.
بعد قديش دكتور من البرومبوزيشن نرجع نعمل ريكروتمنت؟
والله شوف هم عاده بيحكي لك انه طبعا لان اللنج ريكروتمنت يعني انت بتعطي هاي بيب، وخصوصا اذا ما كان في استجابه لنج سبير عاده احنا ما بنفضل نعيدها كثير بس انت طبعا اذا انت عملتي له برونينج وهالكلام يعني ما في غلط انه نعمل له اياها مره ثانيه، نتاكد انه بالفعل ما تحسنت. اذا عملناها مره ثانيه وما تحسنت، على الاغلب يعني على الاغلب حيكون للاسف ما في داعي نعيدها مره ثانيه، لانه بالعكس احنا هيك بنعرضه لخطر اكثر منه انه يعني انه نحاول نحسن. لانه في الحاله هذه اذا حتى على البرون ما تحسن، معناها انه خلص اللانج از فيري ستيف، ومش يعني الوضعها مش يعني ما راح تستجيب يعني.
دكتور once optimize the patient على هاي بيب وهو تحسن صار الساتوريشن عليه كويس وضغطه كويس، بس هو ستيل هاي بيب، وقتاش رح نرجع نعمل له optimization مرة ثانية؟
على طول. شوف انت
نقلل
السيناريو
بنقلل 2 ب2 نقلل 2
ايوه الحين زي هاي الحاله الاولى، احنا لما نحطه على 40، لما نحطه على 40 وتحسن ونشوف الساتوريشن، احنا في كثير مرضى بتحسن من الساتوريشن 100%. ايش بنسوي؟ خلص معناها انه هذا اللانج از ريكروتبل لانج. زي ما حكى حتى محمد نبيل، حكى لنا انه انت لما عملت لانج ريكروتمنت معناها انت فتحت الالفولاي، فانت ليش بدك الاوبتيمال بيم؟ على اساس انه تو مينتين اللي فتحناهم خلوهم موجودين. عشان كده احنا بندور على الاوبتيمال بيم على طول راسا بعد ما تخلص 40 سكند بنبدا على طول راسا بالبيم اوبتمايزيشن. تفهم علي؟ على طول بنحطه طبعا على 40 على طول بتنزل ل 20 طبعا لانه ما في حد يعني بيقبل انه يكون مريضه على بي 20. فهمت كيف علي؟ يعني عاده احنا حتى اور براكتس صراحه الماكسيمم وصلنا 14 تكون معك صحيح يعني بس هو في الكتب ممكن توصل حسب كل مريض ومريض، بس يعني بالبراكتس اكثر من 14 ما شفنا بيب يعني اكثر من 14. فانت ابدا ب 20 بتنزل 2 وبتسجل كل اثنين، بتستنى عليهم دقيقتين، بتطلع على اللانج كومبلاينس، بتطلع على الساتوريشن وعلى الفيتال ساينز، وبتنزل وبعدين بنقارن ايش افضل لانج كومبلاينس مع افضل ساتوريشن، هو هذا اللي بيكون تبعنا الاوبتيمال بيب تبعنا.
تمام.
تمام دكتور.
طيب ايش في اسئله؟
والله ما شاء الله يعني الشرح هذا حلو جدا كثير. هي للاسف بس كان الاول الصوت مش واضح، بس حاليا الامانه اوضحته وجزته كل شيء. يعطيكم الف عافيه دكتور.
الله يعافيك. فاحكوا لنا هذه يعني فرصه، خلينا نسمع اذا في اي سؤال اي حاجه، خلينا يعني طالما موجوده عندنا الشاشه نحكي. فشوف لي اذا في اي سؤال، وانت كمان دكتوره مجد اذا في اي سؤال.
يعطيك العافيه دكتور، أول كان الشرح ممتاز جدا.
طيب خير ان شاء الله باذن الله، وان شاء الله حنتواصل مع قنديل نعيدها مره ثانيه كمان باذن الله يعني.
ان شاء الله. يسلم ايدك دكتور، والله ما شاء الله عليك، يعطيك العافيه.
شكرا جزيلا دكتور عبد الرحمن، شكرا دكتوره مجد. اللهم صل على سيدنا محمد. بعتنا برضو على الجروب 2 اللي هو 2 بيبر على الريكروتمنت والبيب اوبتمايزيشن. can be printed also out and you can keep it in the bedside. It's also helpful to do the whole measurement like static compliance, saturation, blood pressure, and to use it in the clinical practice. We can have another scenario with 2 other audience if they are ready. I'm not sure.
خليني انا لحظه شوي محمد، خلينا بس اروح للسيناريو الثاني اساس الشباب يكونوا موجودين. انا بدي اطلع من هذه خليني اطلع من هاي بس اوكي. طيب يلا الحين جاهزين السيناريو الثاني؟
خليني اختار بس 2، ما اخترت لحتى الان.
يلا اختار انا، خليني احضر شوي الوضع.
يلا 30 seconds. If anybody interested, send me message. Otherwise, I will select randomly. I don't know everybody, so the one who is working in ICU has a priority. Like Dr. Yusuf Al-Asmar, Sumaya, Dr. Soha, Dr. Salman, Dr. Mustafa, Dr. Muhammad Hassan. If anybody interested, can hear Dr. Muhammad Al-Bakr, Dr. Hussam Abu Safiya. Anyone interested, just send me message or unmute. I will allow you to unmute yourself. So anybody can unmute himself and just go ahead.
ايوه محمد، في حد؟
I will select. I will see Dr. Tamer.
طيب
Dr. Tamer, can you hear me?
ايوه سامعك انا.
حياك الله دكتور تامر.
اهلا وسهلا اهلا وسهلا.
اهلا بك. You will help us with the second scenario ان شاء الله. Okay.
مرحبا دكتور تامر.
اهلا وسهلا دكتور.
You to choose أنا one of your colleague.
ايش نتوكل على الله نبلش؟
لا بدنا نختار كمان واحد معاه.
نختار لك.
دكتور تامر مين بدك معك يكون؟ في حد معين؟
الدكتور حسام.
دكتور حسام، يلا دكتور حسام go ahead. Dr. Sam, can you do unmute first? Dr. Hassam is, I think still cannot do any. Dr. Hassam, can you hear me? Okay, I'll choose like randomly في دكتورة سهى الوادية. Can you help us with this scenario? دكتور سلمان المشهراوي. خلاص نو بروبلم، الجو الدكتور تامر.
دكتور تامر.
نعم.
طيب يلا الحين دكتور هينا يعني على نفس السيناريو، نفس المريض زي ما حكينا انه كوفيد 19 دايجنوست، الحين دخل بين سيفير اي ار دي اس وسبتك شوك انتوبيتد وفنتليتد، وبدا على نوع ادرين سمول دوز، وزي ما حكينا حسب طوله 175 هيز ايديال بودي ويت 70. خلينا نبدا الحين يا دوب عملنا له انتوبيشن جاست ناو. ايش قدامك شايف؟
بطلع على الفيتال ساين، بشوف عندي البلس 112،
الساتوريشن فيري لو،
السات 5، السات هايبوكسيا،
اوكي
دي ساتوريشن، البلاد بريشر
مش موجود، بس اعتبره معقول مع انه ادرين. بس في عندك شيء ثاني، شايف السي او 2 الكربون دايوكسيد عنده عالي 56.
صحيح.
واللاين كومبلاينس هذه سي هذا البي سي او 2 عالي 56 عالي. واللاين كومبلاينس عندك فيري لو، شايف 9 يعني ولا شيء. كيف علي؟ اللاين كومبلاينس عندك جدا اقل، يعني عارف ان احنا اقل من 40 هذا بيكون يعني فيري لو لاين كومبلاينس. ماشي، عندك 9 فيري لو. فهمت كيف علي؟ ايش اول شيء بنسويه؟
في البدايه بشوف الاكسجين.
حلو، اول شيء زي ما حكيت ال 40 لازم نرفع الاكسجين. خلينا نرفعها حاليا ل 60 مبدئيا اول حاجه، ونشوف كيف الوضع، لانه احنا بدنا نحافظ زي ما حكينا على الاكسجينيشن 90 ما فوق، عشان يعطيك شويه يعني روم انك انت تسوي الاوبتمايزيشن وتسوي الريكروتمنت. اوكي، طب هينا رفعناها ل 60، لكن للاسف للحين لسه 65 ما تحسن.
صحيح.
خلينا نرفعها كمان زياده، خلينا نرفعها كمان ل 80 ونشوف كيف الوضع. طيب خلال ال 80 ايش كمان في اشياء ممكن نسويها؟
على البيب.
حلو، على البيب زي ما حكينا. نبدا بقديش؟
نبدا ب 10.
حلو، نبدا ب 10 حاليا. لاحظ ان عندك كمان التايدال فوليوم، ايش بدك تسوي فيه؟ هو قديش وزنه؟ قلنا 70 صح؟
70
420
فوق ال 420.
طب لما تحط انت 420 عينك على البيك بريشر. ماشي، البيك بريشر حاليا 41 يعني نوعا ما معقول. وايش كمان عندنا حكينا نرفع نسبه الريت. ماشي، لانه من الفنتليشن عندك 5 المينت فنتريشن انت عارف هي حاصل ضرب ايش؟ الريسبيراتوري ريت في التايدال فوليوم، عندك 5 لو، احنا بدنا نرفعها فوق ال10 لانه عشان نعمل شويه واشنج للسي او 2. خلينا نرفع الريت، نرفعه مثلا
ل 20.
اوكي ماشي. طيب رفعناها الحين ل 20. لاحظ البي سي او 2 قاعد تنزل قاعد تتحسن شوي شوي ماشي. لاحظ الاكسجينيشن بدات كمان تتحسن ماشي شوي شوي. حالي ها لاحظ البي سي او 2 كيف بدات يعني بدات نورمالايز، ولاحظ المينت فنتريشن بدات تتحسن عندك ماشي، قربت على 10 ماشي.
صحيح.
طيب ايش حكينا الحين؟
ممكن احنا مثلا لو رفعنا برضه الريسبيراتوري ريت ل 25 مثلا
ممكن بس انت 20 هي قاعد تتحسن، السي او 2 تقريبا بدا يرجع نورمال، فهمت كيف علي؟ 45 يعني انت عارف النورمال يعني الحين تقريبا وصلنا للنورمال، فهمت كيف علي؟
صحيح.
طيب الحين زي ما حكينا اول خطوه حنسوي اللانج ريكروتمنت، بتساعدنا بحاجتين، بتساعدنا في الاكسجينيشن وبتساعدنا بتعطينا هنت ودايجنوسيس انه هذا اللانج ريكروتبل او مش ريكروتبل ماشي. اللانج بنروح زي ما حكينا بنحطه على 40 بس زي ما حكيت لك هنا 25 بيطلعش في الجهاز من 25 اعتبرها 40، نحطها من 20 ل 40 سكند ماشي.
محمد بعت رساله قال لك لو زودت الالارم على increase the high pressure limit so you can go beep 40.
طيب اوكي.
increase the high pressure limit so you can go to beep 40.
هي رفعتها للماكسيمم.
اعتقد انك تقدر تزود البيب.
we tried دكتور. مو نبيل سند
طيب لحظه شوي اشوف له.
It's going 25.
لا والله ما زبطت.
I tried. Can you send a message? I tried.
طيب اوكي ما فيش مشكله. طب دكتور تامر ايش ملاحظ الحين؟
الاكسجينيشن تحسن ل 92.
ممتاز.
والسي او قلت.
طيب حلو، يعني الاكسجينيشن تحسن معناها هذا بيعطيك هنت انه هذا اللنج شكلها ريكروتبل لنج صح ولا لا؟ في الحاله الاولى ما تحسن الاكسجينيشن معناها انه اللنج برستت، هنا اللنج تتحسن. ولاحظ الكومبلاينس بدينا ب9 الحين 30 صح؟
صحيح.
يعني معناها الكومبلاينس تبع اللنج عم تتحسن، معناها انه هذا المريض بيعطيك هنت انه هذا المريض اللنج تبعته مش ستيف، وانه ممكن انه تتحسن مع البيب. زي ما حكينا خلصنا اللنج ريكروتمنت، الساتوريشن بدها تتحسن، هي تحسنت. الحين بنروح بدنا نعرف الاوبتيمال بيب، تنزل في البيب تبعك ل 20 ماشي؟ 20 وبنسجل الحين 20 بتسجل الكومبلاينس تبعك وبتسجل الساتوريشن ماشي؟
الساتوريشن 95
واللاين كومبلاينس تبعك
31.
نستنى عليهم دقيقتين وبعدين بننزل نعتبر انه دقيقتين راحوا، ننزل ل 18 ماشي؟ وبنسجل اللاين كومبلاينس عندك 31.6 شايف كيف؟ 31.7 والساتوريشن قاعد تتحسن شايف كيف؟ حتى زادت والساتوريشن زي ما هو. بعد دقيقتين بتنزل يا دكتور تامر تخليها 16 بعد دقيقتين. طبعا احنا بنستعجل شوي هان لانه بس لانه سيميليشن، بس هو في الحقيقه اصبر عليها دقيقتين.
ننزل ل 14.
ننزل 14. خلينا نشوف اللانج كومبلاينس بدأت تنزل صح؟ معناها الاوبتيمال بيب اللي عند الميت هذا كان حوالي 18 ماشي؟ خلاص يعني طالما عرفنا هيك بنحط المريض على الاوبتيمال بيب اللي هو 18 وهذا هيز اوبتيمال بيب ونكمل الفنتيلتر زي ما هو ماشي؟ طيب بعدين النقطة الثانية، أنت الحين بتخليه على البيب اللي هو اوبتيمال سواء حسب المريض، سواء طلع 14 طلع 16 طلع 18 بتخليه. النكست ستيب طبعا أنت بتعيد البلاد جاز بعديها مثلا بنص ساعة لساعة وبتشوف الوضع. النكست ستيب بننزل بالاف اي 2 ماشي؟ النكست ستيب ننزل في الاف اي 2 لو يعني وبدنا احنا ساتوريشن 90 فما فوق بننزل بالاف اي 2. بنقربش ابدا، هذه نقطه مهمه جدا، ما بنقرب ابدا على البيب ماشي. طالما هذه امتى بنقرب على البيب؟ في حاله واحده، اذا وصلنا ل يعني رقم معين، يعني مثلا نقول تقريبا وصلنا حوالي 40 ل 50 اف اي 2 حينتها بننزل شوي شوي في البيب. بس طالما ما وصلناش 40 ما حدش يقرب على البيب، لانه احنا اذا نزلنا في البيب استعجلنا نزلنا في البيب احنا حنسوي دي ريكروتمنت اللي ما بدنا اياها، دي ريكروتمنت. ماشي. فانت اول ما الست الاوبتيمال بيب خلاص حينتها ما بتغير الا في الاف اي 2، انزل فيه بالتدريج وخلي الساتوريشن تبعك 90 فما فوق. اذا وصلت يعني مثلا نتكلم بعد 6 ساعات 12 ساعه وصلت مثلا انك انت المريض ستيبل على اف اي 2 40 ل 50، حينتها بنبدا نفكر شوي شوي ننزل في البيت. بس كمان لما ننزل شوي شوي سلولي، لانه اذا نزلنا بسرعه نعمل ريكروتمنت، ومرات كثيره انك تعمل ريكروتمنت اجين بيكون الموضوع ديفيكلت.
طيب ننزل في الاكسجين.
هاي احنا 70 ننزل فيه نحطه مثلا 60. 60 انت عارف عند هو 60 عاده هو يعتبر يعني الهاير ليميت في السيف، لانه اكثر من 60 تعرف الاكسجين بحد ذاته توكسيك. فاحنا دائما اول هدفنا انه دائما نوصل عند 60. يعني انت لما تكون 60 بتكون شويه يعني ريليفد شويه، لانه يعني اي شيء ابوف 60 معناها المريض هذا يعني بنعطيه توكسيك ليفل. بس طبعا اذا مرات اذا هيك اذا الامور يعني مش قادرين خلاص الله غالب ايش نسوي.
السات صار 90
مش مشكله، حتى لعند 88 معقول، فهمت كيف علي؟ حتى لعند 88 مش مشكله، فهمت كيف علي؟ طبعا اذا السات اذا نزل عن 88 خلص بعين الله بنرجع نرفع الاف اي 2 مره ثانيه شوي شوي. في اي سؤال؟
نو ثانكس.
يمكن السؤال الاول تحكي عن نقطه اللي هو متى نعيد الاي بي جي، متى نعمل البرونينج.
طبعا الاي بي جي انتم عارفين احنا الاي بي جي على طول اول يعني عاده لما نعمل انتوبيشن المريض يعني وراها مثلا بنص ساعه ناخذ بلاد جاز از بيز لاين عشان نعرف احنا وين متجهين ونحسن البي اف ريشيو. وبعد ما نسوي لانج ريكروتمنت ونسوي اوبتيمال بيب عاده وراها كمان بنص ساعه بنعيد الاي بي جي عشان نشوف كيف الوضع بيصير. يعني عاده احنا بعد كل يعني اذا تشينج بسيطه يعني بتتكلم مثلا على 1 ل 2، اما اذا كان ميجر تشينج مثلا سويت شيء كبير مثلا نزلت كميه كبيره حينتها بنسوي عاده اي بي جي يعني خلال نص ساعه لساعه بعد اي تشينج. موضوع البرونينج اذا المريض زي ما حكينا عملنا اللانج ريكروتمنت وشفنا ما تحسن الساتوريشن، فهيك احنا كنا اتفقنا انه هذا اللانج معناها ستيف ونت ريكروتبل لانج. حينتها خلص حينتها بنروح على طول بنباشر في موضوع البرونينج، بنعمل برونينج للمريض وبنخليه. وزي ما حكيت لك ما في مانع انه احنا بعد ما نسوي برونينج ونطمن انه فايتال ستيبل نعمل انذر ترايل ريكروتمنت. يعني لانه في بعض المرضى بتحسنوا، يعني بعضهم بتحسنوا لما يكون برون يعني ريكروتمنت ممكن تلاقيها جابت افكت. يعني
دكتور محسن supposed انه هذا البيشنت كان recruitable we set the optimum beep for such number and his saturation was fine 90 and his BF ratio like 140 150. He is sedated and paralyzed. How to wean him off from the muscle relaxant?
شوف المسل ريلاكسنت طبعا هذا سبجكت كثير يعني عاده زي ما انت عارف كل البيبرز بتقول لك انه مرات يعني انه تو كونتينيو 48 اورز ماشي، لانه يعني انت عارف المسل ريلاكسنت انه مرات لقوا انه فيها افكت مثلا يعني قلت افكت في الاي ار ديس ممكن عادي ممكن تخلي المرضى 48 اورز. لكن لاحظنا احنا يعني قلت لك في الكوفيد الاشياء مختلفه، لان انت في الكوفيد لا تنسى ان انت قاعد تعطي هاي دوز ستيرويد ديكساميثازون الامور هاي. ففي الكوفيد صراحه طلعنا برا شوي على القاعده، صرنا بنحاول انه نوقف المصر لاكسنت as soon as possible، اساس بدناش انه نعرض المريض لمصر لاكسنت مع ستيرويد بيدخل مثلا تدخل في كريتيكال كير مايوباثي والامور هاي. بس بشكل عام بالمرضى الثانيين لما كنا غير الكوفيد كنا عاده مرات بنكمل عالي 48 ساعه على المصر لاكسنت لحتى نطمن انه كل شيء تمام. بس زي ما حكيت لك في الكوفيد سبحان الله كل شيء تغير، وحتى البراكتس تبعنا طبعا كل شيء يعني حسب الهاي، انه لاحظنا انه as soon as possible انه ننزل في المصر لاكسنت في الكوفيد يعني.
Dr. Mohsen, I'm not sure there is Hamilton in Gaza or no. Dr. Tamer, you have Hamilton ventilator or no?
لا no.
Because in Hamilton, you might get, we don't know, there is some specific mode called ASV mode. And a lot of our consultants, especially in COVID hospital, they prefer this mode for COVID patient. Hopefully, if this Hamilton ventilator will be available in Palestine,
Okay.
you can just will give you a hint about something called ASV mode.
ايوه.
Okay, yeah, you can go ahead, Dr. Mohsen or Mr. Damo, just 5 minutes. Very easy, very helpful in us. The ventilator is like intelligent mode, can do the job by itself.
ASV mode.
ASV mode, yes.
Control mode.
Just briefly with the one scenario of ARDS patient.
Nabil, you are there?
Yeah, we'll go back to the mode, to the ASV. Go back,
Yes,
Mr.
Damo. I am there. Yes, Damo.
Nabil can go with the ASV mode clearly more than me.
Thank you so much.
Nabil.
Thank you.
Go ahead.
So just to make it simple, the ASV mode is a combination between two pressure modes, a pressure controlled mode and a spontaneous mode. So you will put the settings, as you can see on the shared screen from Mr. Damo. You put the one setting only to control the CO2 elimination, which is the percentage minute volume. And you will put two settings for the oxygenation, which is PEEP and FiO2. As Dr. Mohammed Kandil said, that this mode is available only in Hamilton ventilators. So inshallah, if maybe in the future you will have Hamilton ventilator in your ICU, you will be able to use this patent mode for Hamilton. So as you can see here, you are decreasing the human inputs that you can put it for the patient. I mean, you will have control only for 3 parameters, and all the other parameters will be controlled by the ventilator. So as you know, the minute volume is equal to tidal volume multiplied by respiratory rate. When you will say that I will give this patient 100% minute volume, that means you will give this patient 0.1 minute volume per kg as an ideal body weight. So let's say, for example, that our patient is 70 kilogram. So with a 100% minute volume will equal 7 liters per minute as a minute volume. To give this patient 7 liters per minute as a minute volume, it will be unlimited multiplication between the tidal volume and the respiratory rate. So the ventilator, based on the algorithm, which is inside the ventilator itself, it will calculate for the patient the optimum tidal volume and the optimum respiratory rate based on two equations, mean equation and Otis equation. And it will make sure that all the time your patient is doing the minimum work of breathing. So you can imagine that just only by using one parameter, which is the minute volume, the ventilator will decide for you the best tidal volume, the best respiratory rate, the best IE ratio, inspiratory time, etc., just only by using one parameter. To control the oxygenation, you need to play with the PEEP and the FiO2. So based on the patient condition, the ventilator will choose what's the optimum mood that it will be used. If the patient is fully sedated, it will be a pressure controlled mandatory mode. If the patient is taking some respiratory rate, it will go for splint mode. And this transition will be cycle by cycle, breath by breath, based on the patient condition again. And we have a very important parameter, which is our ventilator is monitoring it, and it's very helpful for the ASV algorithm. You can see on the left side of the screen of Mr. Damo, the last arrow, it's called RCEXP. This is the multiplication between resistance and compliance, and it's called time constant. If the time constant is between 0.5 to 0.7 seconds, that means that you are dealing with a normal lung. If it's more than 0.7, it will give you an indication that this lung is a restrictive lung disease, and the ventilator will start to do that changes based on the patient lung mechanism. So again, these things that you can find it in the ASV mode, just to make it simple for you. It needs a long lecture actually to talk about the ASV, but just to make it simple, this is how the ASV is working. And by the way, there is no contraindication of using ASV. You can use it from the time of intubation to the time of extubation for all kinds of patients, regarding less what the patient condition, ARDS, COPD, brain injury, whatever. Thank you.
Thank you very much, Muhammad Nabil. Thank you for your help and cooperation with us today. Hopefully, we can do another session, inshallah, upon the request of our colleagues in Palestine. We are ready anytime to do any session if they have specific things or they have specific cases or any specific topic. Tomorrow we are continuing with the lectures, inshallah, till Thursday. We have another workshop using the X-Lung, inshallah, and it will be helpful. At the end, I would like to thank Dr. Nader, Dr. Mohsen, and Mr. Damo for their help and support. They buy their own times to help us making this course helpful and real for our colleague in Palestine. Thanks for Muhammad Nabil also again. Thanks for the audience and our colleague in Gaza and West Bank. They are fighting now the COVID-19. Hopefully this trouble will end soon. And at the end, I would like to say Assalamu alaikum. See you tomorrow, inshallah.
Thank you very much. Thank you.
Thank you.